Good afternoon and welcome to the April P&T committee meeting for the Oregon Health Authority. This meeting is being recorded. Just wanted to be aware. We have another committee member that just joined us. We'll be doing introductions shortly. So we do have 6 members for a quorum, expecting one more, but we're definitely in a position to get going with a pretty robust agenda. So general instructions are on the screen. For those in the audience, if you haven't already done so, please add the affiliation. If you work for a CCO or if you work for industry, appreciate you appending that to your name, just so we can capture that for the minutes that will be recorded. So we're going to start with roll calls and introduction. On the screen, we have the list of the committee members with their representative, their physician, pharmacist, or public member, their term expiration dates, and we're going to start at the top. So Doug, we'll turn it over to you.
I'm Douglas Carr. I'm Chief Medical Officer at Umpqua Health in Roseburg.
Welcome, Doug. Russ?
Hello again. I'm Russ Huffman. I'm a psychiatric nurse practitioner at Salem Health.
Welcome, Russ. Dr. Nishi hasn't joined yet. I'm hoping she joins us shortly. Eddie, we'll turn it over to you.
Hi, Eddie Saito, Associate Professor with Pacific University School of Pharmacy and Clinical Pharmacist with Virginia Garcia.
Welcome. Pat isn't able to join us, so Kat, we'll turn it over to you.
Hi, Kat Livingston, Medical Director of HealthShare and practicing family doctor.
Welcome, Kat. Stacy also isn't able to join, so Tim, we're to you.
Good afternoon. I'm Tim Langford. I'm the Pharmacy Director with the Klamath Tribes in Klamath County, Oregon.
Welcome, Tim. And Bridget.
Yeah, hi, my name's Bridget Bradley. I am a clinical pharmacist at OHSU.
Welcome, Bridget. And Dr. Anishi is just joining. I'm making her a co-host, so I'm going to put her on the spot. Dr. Anishi, we're just doing introductions. Are you able to unmute your line?
Can you hear me?
We can hear you. Thank you.
Oh, hi. Thank you. Eriko Nishi from Family Medicine OHSU.
Welcome. Appreciate it. And we'll also turn it over to staff. So Jennifer, we'll let you lead off.
Jennifer Bowen, Executive Support, Oregon Health Authority.
And I'm Roger Citron. I'm the Director of the Drug Use Research and Management Program. We provide the clinical support to the OHA and help administer these P&T meetings.
I'm Trevor Douglas. I am the OHA's Pharmacy Director.
Hi, I'm Dave Engen, Clinical Pharmacist with the OSU Derm Group.
Hi, I'm Sarah Fletcher. I'm one of the clinical co-coordinators for the Derm Group.
Andrew Gibler, Clinical Pharmacy Manager for OHA.
Kyle Hamilton, Pharmacy Drug Coordinator with the OHA.
Megan's on our team but won't be joining us today. So Deanna?
Hi, good afternoon. I'm Deanna Moretz. I'm a pharmacist with the Drug Use Research Management Team affiliated with the OSU College of Pharmacy.
And I'm Kathy Centena, and I'm also a clinical pharmacist with the OSU College of Pharmacy Derm Group.
Hi, I'm Sarah Servid. I work as a P&T clinical coordinator for the Derm Group.
I'm Starkweather, Pharmacy Manager for Gainwell Technologies.
Hi, Dee Weston, Pharmacy Program Policy Advisor with OHA.
And I'm Brandon Wells. I'm the Pharmacy Program Analyst at OHA.
And we don't have Ted with us either, so no TED Talks today. So the agenda is in front of you. The only addition or amendment I have to what we're planning to present today is the insulin literature scan, which is part of the consent agenda. We're once again going to defer that topic as we're waiting for updated rebates so we can accurately make decisions and recommendations for PDL placement. So again, we're going to save a little time and defer that topic, ideally to the June P&T meeting. So conflict of interest declaration, staff, committee, all the P&T members have a updated conflict of interest declaration on file with the OHA. Anybody wishing to provide public comment today has also been asked to fill out a more brief conflict of interest declaration, but it's important for the committee to be aware of any conflicts that members might have. There's an expectation that if there was a subject that a member might have a conflict with, they would recuse themselves. We don't have any of those that I'm aware of, but we also provide this opportunity for any committee members to disclose any new conflicts that may have recently arisen that you need to bring to attention to the committee. So pause for a moment. Hearing none, we have the approval of the agenda and the minutes. If you're following along in the packet of materials on our website, we have posted the materials. We've also given the minutes out. So we'll ask the committee, if you're following along, it's on page 3 in the packet, but see if the committee has any edits to the draft minutes, or if not, we need a motion to approve.
Motion to approve the minutes.
Thank you, Doug.
Second.
Thank you, Russ. All in favor?
Aye.
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 Any opposed? Any abstentions? Great. We'll also do a department update. So at this time, we're going to turn it over to Andrew Gibler.
Thank you, Roger. I'll be really quick because I also know Dee Weston needs to give her legislative update on our short session. But our new director, OHA director, Dr. Cecil Hathey, has been here for about a month now, and she's been very engaged. We've appreciated her leadership so far. The Mental Health Clinical Advisor Group has been meeting monthly, and so far this year, we approved new treatment guidance for schizophrenia and acute antipsychotic-induced movement disorders. The schizophrenia documents are on the website. I encourage you to all look at that. And the movement disorders document was approved this morning, so we will get those posted here in the next week or so. And do want to remind everyone, if you know a physician who is interested in joining the committee as a member, we would really appreciate having another physician on the committee. We also need a public member. So anyone that would have an interest, please encourage them to reach out to Roger or myself. And then personally, in our division, we've had our division's deputy director is retiring in June, so we'll be recruiting for a new deputy director of health policy and analytics. And in our own division, we welcomed a new member, Dr. Michael Yu. He's new to our team, and he's going to be serving as community pharmacy partner liaison and assisting everyone with some policy analyst duties. So we're appreciative of him joining our team. He's been with OHA for a while and is coming over to our division. And with that, I'm going to pass it on to Dee for a legislative update.
Hello. I watched many bills this session, and I had 3 that I wanted to just quickly go over with you to make sure you're aware. The first one is House Bill 4002. That relates to the addiction crisis in the state, and there were a number of lots of different parts to it. There were a couple that were particular to pharmacy. First one prohibits CCOs from requiring prior authorization for brand name drug for medication assisted treatment if there's a generic equivalent available. And this applies only to medications that are FDA approved on or before January 1, 2024. And OHA will be working on implementation while the statute specifically says CCOs. We generally adopt those same requirements for fee-for-service. And another part of the bill allows pharmacists to prescribe and dispense early refills of medication for opioid use disorder under specified conditions. The Oregon Board of Pharmacy will be developing rules on this. I think, Andrew, you shared that this would be only concerning buprenorphine products or buprenorphine containing products.
I mean, the OARs that the Board of Pharmacy will construct will delineate all that, but that is the major assumption now.
Okay, thank you. So that's House Bill 4002. The second bill I wanted to touch on is Senate Bill 1506, which is about test to treat. It extends the current program that allows pharmacists to test a person for COVID and then prescribe medication. Currently, that program would end June 30th, 2024. The bill extends that an additional 2 years and requires OHP to continue to cover that. The final bill I wanted to mention, and I don't have a lot of detail at this moment, but it's House Bill 1508. This is legislation that was passed that concerns treatment of quality of life in general measures by HERC and the Pharmacy and Therapeutics Committee, P&T, you all. It defines quality of life in general measure as an assessment of the value, effectiveness, or cost effectiveness of a treatment that gives greater value to a year of life lived in perfect health than the value given to a year of life lived with less than perfect health. To the best of my knowledge and understanding, this new legislation will take effect January 1st, 2025. OHA is looking to determine what, if any, changes need to be made for the P&T committee and Durham group for developing materials for the P&T committee. And that is all I have. Are there any questions about these or other bills?
Great job.
Great, thank you.
And we are right on track. So we're with the consent agenda. I'm going to take myself off camera because it's very distracting as I'm trying to multitask and make sure I don't miss any late additions to the public comment. So with that, we have as part of our consent agenda a couple classes that will be going to review executive session. There's no new clinical information that would warrant discussion or changes. It's primarily one to take advantage of our policies like the oncology policy to add new drugs and to look at some pricing. So it's up to the committee if there's any topics you wish to pull off the consent to discuss. If not, we would request a motion to approve the consent agenda topics.
Motion to approve consent agenda topics.
Appreciate it,
Second.
Eddie. Thank you, Doug. All those in favor?
Aye.
Aye.
Anyone opposed? Any abstentions? Great. Any topics that we discuss in executive session, we won't make any decisions there, but we'll come back to open session to make recommendations. So again, if you're following along in the packet of materials, we're going to the DUR new business. Draw your attention to page 116 in the packet, and we have the orphan drug policy updates. So Sarah, I'm gonna turn it over to you.
Thanks. Yeah, this is a topic that's usually on the consent agenda, but we've pulled it off because we're reformatting it a little bit and wanted to kind of draw your attention to how it'll be formatted going forward in future. And so the purpose of this policy is to kind of preserve staff and P&T committee bandwidth for drugs that are used for orphan conditions, meaning they're very rare conditions. And so we rarely see claims for them in fee-for-service because of the population size that's enrolled in fee-for-service. And so when new drugs come across that are categorized by the FDA as an orphan, as approved under the orphan drug pathway, they can get considered under this policy, and we'll add them when they get approved. And the modification that we're recommending is in the prior authorization criteria. We're recommending to just include a link to the FDA labeling. Historically, we've outlined the indication, age, dose, and recommended monitoring that's in the FDA labeling. And because we use this PA criteria so rarely, I think it's been used once in the 4 years that we've had it. We're recommending just including a link to the label to kind of preserve bandwidth a little bit farther and make this criteria easier to read. But I'm happy to take questions if you have them.
Any questions for Sarah or the intended changes to the policy? Okay, so the recommendation in front of the committee is to simplify the criteria by linking to the FDA label instead of including the details in the PA. And we'll include new recently approved orphan drugs in this policy that have recently come out here. Any discussion or motion to approve? Doug, you
Motion
got
to
the,
approve.
yeah, thank you. Do we have a second?
Second.
Great, thank you, Russ. All those in favor?
Aye.
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 Any opposed? Any abstentions? Great, thank you. Next, we're going to turn it for DUR new business to the TEPEZA PRE update. It's on 127 in the packet of materials, and Sarah Fletcher, we'll turn it over to you.
Thanks, Roger. Can you hear me?
Yes, loud and clear. Thank you.
Great. So we are going to do a prior authorization update for teprotumumab or TEPEZA. You can go to the next slide. The purpose of this is to review the new evidence for efficacy and safety and to align the PA criteria with an expanded FDA drug indication based off of the results of a new trial. So if you go to the next slide, we did previously review this drug in 2020. At the time, it was approved for the treatment of thyroid eye disease, but it was only studied in patients with active thyroid eye disease. It was designated at that time as non-preferred, and it does have specific prior authorization criteria associated with it. Next slide. In doing this PA update, I also looked for guidelines and systematic reviews and that type of thing. And there was a new updated guideline from the American Thyroid Association and the European Thyroid Association that had good methods. And they did recommend IV steroids as the preferred treatment for active, moderate to severe TED or thyroid eye disease when the disease activity is the prominent feature. And that's usually measured by something called the clinical activity score. And in the absence of significant proptosis or double vision. A poor response to IV steroids could prompt consideration for withdrawal and other therapies, which could be teprotumumab, rituximab, tocilizumab. There are a few other options. And to be alert for worsening double vision or optic neuropathy while on steroids. They did note that teprotumumab is a preferred therapy for certain patients with significant proptosis or double vision, and that there might be some populations where it might be considered over steroids as the first step, and those can include chronic infection or liver disease. If you go to the next slide, there were a few new label indications and safety updates that have happened since 2020. The new indication, previously it said approved for thyroid eye disease, and now it's regardless of activity or duration, and that's in the review. But there were also some labeling updates. The first one was the warnings and precaution, where it's noted that this drug can cause hyperglycemia, and they just strengthened the language a little bit and to ensure that patients received appropriate glycemic control before treatment and while receiving it. This therapy is given every 3 weeks for 8 doses, so it's over a course of several months. And then in July of 2023, there was a new subsection added, and this was for hearing impairment, including hearing loss. And it was added that it can cause severe hearing impairment, including loss, which may be permanent, and that patients should be assessed before, during, and after treatment to consider the risk benefit. So if you go to the next slide. So what prompted this update with the new indication is a teprotumumab study in patients who have long duration of disease or low disease activity. Typically, this disease starts with active inflammatory type symptoms, and then it can move into a more fibrotic inactive stage. So this was a double-blind, placebo-controlled, randomized phase 4 trial. The medication, as I mentioned, was given every 3 weeks for a total of 8 doses. It was a randomization of 2 to 1, so 42 patients in the teprotumumab group and 20 in the placebo group, primarily age in the 40s, mostly female, which is consistent with the disease itself. About half of the patients were white, and about a quarter of them were identified as Black. And it was about 5 years from diagnosis. About 13% had current tobacco use, and that's important because tobacco use increases the risk of developing TED and also makes it more difficult to treat. The inclusion criteria were for adults. They had stable disease. They had at least 3 millimeters of proptosis, and then were euthyroid with a duration of 2 to 10 years and a clinical activity score of 0 or 1. Usually 4 or above is considered active disease. They were excluded with certain surgical conditions, optic neuropathy, other medication treatments, not historically, but currently there were some washout periods, and then pregnancy, high hemoglobin A1C, or an active or short remission duration of IBD, ulcerative colitis, or Crohn's. So if you go to the next slide with the results, The primary outcome was a change of proptosis from baseline, and you can see that that was statistically significant. And then the secondary outcome of proptosis responders with a change of at least 2 millimeters reduction in baseline proptosis, that was an absolute risk reduction of about 37% and a number needed to treat of 3. And that is considered to be a clinically meaningful change in proptosis for most patients. They did also do some quality of life studies or quality of life outcomes in this study. And this was the Graves Orbitopathy Quality of Life Scale. There are 2 subscales, and a change of 6 is considered to be clinically meaningful. The visual function subscale was statistically significant, whereas the appearance subscale did not find a difference in the 2 therapies. If you go to the next slide, the general trial limitations, it's fairly short duration and a small sample size, and we didn't really know the treatment history, or it wasn't reported as far as what patients have been treated with, but overall the methods were quite solid. Next slide. The safety for this, from this trial, these are the safety results from this specific trial, and they do align pretty well with the previous results we've seen in other trials. Muscle spasm, fatigue, headache were the most common side effects. Hearing impairment off to the right, that was seen in 22% of patients. That was 9 of the 42. And at the end of data, at the end of the, when the, at the time of publication, 3 of the 9 patients were recovering or having improvement in their hearing. So 6 at that time were not. And then there was more hyperglycemia seen with teprotumumab versus placebo. If you go to the next slide, these are the changes in the prior authorization criteria. The first 3 questions are unchanged. It's for adult patients. We do have a step through a specialist. Question 4 is also not changed. It's just moved to a different location, and that's to restrict this to patients who do not have mild disease, basically. If you go to the next slide, question 5 is unchanged. Question 6, the original one, I removed simply to simplify the process a little bit more. Patients are supposed to be euthyroid, but the PA criteria is getting quite complex. Question 6, if a patient does have active disease, they do have a step through steroids based off of our previous review and the guidelines that I mentioned. I did add some clarifying language, and then the first bullet, I've added some additional conditions that would allow a bypass of the step through steroids in specifically active disease. So if you go to the next step, or the next page, I also added a new question number 7, which aligns more fully with the guidelines to skip the step through steroids for patients who have double vision or significant proptosis. And the notation is how significant proptosis was defined. Generally in the literature, it's a greater than 3 millimeters above the upper limit for race and sex, but the guidelines also had a caveat for sufficient severity for patients who maybe don't meet that numeric value. Patients who do not have active disease will skip those steps through steroids and go to number 8. And then questions 9, 10, and 11 are unchanged, and they're related to the pregnancy risk associated with this drug or the fetal risk associated with this drug. And then if you go to the next page, question 11, that's just clarifying language. And then question 12, I've added based off of the new labeling, is there documentation of a risk benefit discussion with the patient related to potentially permanent hearing loss, which is basically consent, and then documentation of a plan to assess and monitor before and after treatment. So those are the PA updates that I'm proposing. Are there any questions from the committee before we go to a public comment? I'm hearing none. Roger?
I am hearing none either. So we do have Dr. Alice Weiss-Jackson with Amgen. I've made you a co-host. Are you able to unmute your line?
I am. Hi, everybody. Thank you very much for the chance to speak. I'm a regional medical director with Amgen. I want to say thank you very much, Dr. Fletcher, for your review of the literature associated with thyroid eye disease and for your thorough policy review of TEPEZZA. It looks wonderful. I'm here as a medical resource if there are any additional questions, but otherwise we'll respectfully give back my time. So thank you.
Appreciate that. Does the committee have any questions? All right. Hearing none, again, the recommendation in front of the committee is to update the PA criteria as proposed.
Motion for approval.
Thank Thank you, Doug. We have a second.
Second.
Turnbull, second.
Doolin seconds. Sounds good. All those in favor?
Aye.
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 Anyone opposed? Any abstentions? All right, motion passes. Thank you very much. So we're moving along in the packet. If you're following along, we're now to the topic of drugs for weight loss. I think a lot of people that have signed up for public comment, I see you in the audience, so thank you for identifying yourselves. We're going to start with Dee Weston, just to set the stage for why we're having this discussion. And so Dee, are you able to unmute?
Yes, can you hear me?
You bet, here, loud and clear. Better
Okay,
than me, I
great.
understand.
Thank you. I think you just fixed it. Whatever you did, the crackling stopped. So I just wanted to just kind of set the stage for the conversation that you all are going to have by saying that under federal law, drugs, when used for weight loss, are an optional benefit. They're considered an optional benefit for Medicaid programs. Oregon has not elected to include this optional coverage so far. Evidence will be presented on weight loss drugs so that the P&T committee, you all, can consider the draft prior authorization criteria and make a recommendation to the state to identify a funding plan before opening coverage. Coverage under the Early and Periodic Screening, Diagnostic, and Treatment Program, otherwise known as EPSDT, can be and is being considered with individual review for members who are under the age of 21. The new cardiovascular indication for Wegovy will be discussed in the June meeting. However, the SELECT trial will be briefly reviewed as it had been published prior to the posting deadline. That's all I have. Roger, are you?
Thank you, Dee.
Okay.
Any questions for Dee about policy, kind of federal law, what our plans are today? Okay, thank you for setting the stage for us, Dee. We're members, Oregon is a member of the Drug Effectiveness Review Project, and the state's elected to commission DERP to do a evidence review of drugs for weight loss. So we have that, and that's part of our presentation today. But to be fair and balanced, we also did a GLP-1 receptor agonist literature scan to kind of tee things up. So Kathy Centena, I'm going to turn it over to you. If you're following in the packet, we're starting on page 141.
Great, thanks, Roger. Yeah, this class is also used to treat diabetes, and so we wanted to review the literature in that regard as well. If you go to the next slide there, you can see that some new evidence was identified. We had one high-quality systematic review, 5 high-quality clinical practice guidelines, 1 expanded FDA indication, 1 updated FDA safety warning, and then 2 randomized controlled trials. This class was last reviewed in October of 2022, so not too long ago. And at that time, we did designate the dual GLP-1 GIP RAs and added them to the GLP-1 RA class just to simplify things. And at that time, tirzepatide was reviewed and kept as a non-preferred agent on the PDL. The preferred products in this class are dulaglutide, exenatide, and liraglutide. And the last quarter of 2023, there were over 300 claims for this class. None of the evidence for this review resulted in any kind of policy changes. And of course, we will look at costs in executive session. However, we wanted to focus our efforts on the weight loss management drugs. So unless the committee wants to dive into this class in more detail, we'd like to suggest that we go ahead and move on to the weight loss management drugs at this time.
So to the committee, the recommendation for this portion of this discussion is no changes to the PDL for the GLPs or the GLP-GIP RAs are recommended based on a review of the evidence, and we'll look at costs in executive session. Does anybody wish to have further discussion, or can we get a motion to approve that recommendation just for this scan?
Motion to approve.
Great, thank you. Second?
Second.
Thank you, Eddie. All those in favor?
Aye.
Aye.
This is Erika Onishi. I guess I just want to make sure that you said that we're going to talk about this in June more, though, the weight loss part.
We're going to talk about the weight loss right now. We're going to dig
Oh.
into the DERP report. It was just that this scan of the GLP-1s, particularly as they're used for diabetes, they're already covered. They were recently reviewed. We're just proposing that that not be the focus right now, that we just talk about the pricing today in executive session for those classes.
Okay, thank you.
You bet. Anyone opposed? Anybody abstained? Great. All right, Kathy, we'll leave it with you if you're following along in the packet. Again, we'll be starting on page 155 at this point.
Great. Yeah, thanks, Roger. So we'll go ahead and go to the next slide there. And Dee did a great job kind of teeing this up for us, so I don't need to repeat everything here. I just did want to mention, though, that the focus of this review, as Roger had mentioned, is a summary of the DERP report and then primary literature and guidelines that have been posted since the time frame of the DERP report, the evidence scan had ended. So if we look at the next slide, I just want to give a little background. So the DERP report focuses on drugs used for management of weight loss for adults and children, as defined by the American Medical Association as those with overweight, so a BMI of 25 to 30, or obesity, a BMI of 30 or greater. Included in this review were those studies that lasted at least 12 months in duration, with exception of those studies enrolling pediatric patients, as well as those with type 1 diabetes, and studies included for setmelanotide. Background therapy with diet and exercise or intensive behavioral therapy was included in all the studies. If we look then at the table there, we can see the drugs starting with the GLP-1s, and you can see that some of these treatments are approved for dual indications, so diabetes as well as weight loss under different brand names. So liraglutide there, approved for weight loss under the brand name Saxenda, and used at a little bit higher dose of 3 milligrams injected subcutaneously daily. You'll see a similar thing for semaglutide, which is used for weight loss under the brand name Wegovy. Again, it used at a little bit higher doses than it is for diabetes, which is used under the brand name Ozempic. You can see that there's other GLP-1s listed there, but they are not approved specifically for weight loss, just for diabetes. Okay, if we look at the next page, we can see that the dual GLP-1 GIP-RA tirzepatide is also approved for both indications, Zepbound for the weight loss indication. However, it's used at the same doses for both indications. And then the other additional miscellaneous agents there, one is naltrexone, bupropion, phentermine, topiramate, setmelanotide, which I wanted to mention is only approved for weight management in patients with genetic variants and those with Bardet-Biedl syndrome. And then last one, orlistat, which is known as Zenical or Ali, the OTC version. And although it was not, no studies were included in the DERP report, it is also approved for pediatrics ages 12 and up. Moving on, just a brief overview of important weight loss outcomes as we start to dive into the evidence for these drugs. Looking at the percent change in body weight is designated as the minimal clinically important difference, is 5% or more. For children and adolescents, they often look at the body mass Z-score or standard deviation score, and the clinically important difference for that's been designated as 0.15 to 2.5 or more units. For percent change in BMI, for adults, we'll see this a lot. It's 5% or more, and then for pediatrics, a change of 1% or more. Moving on to the next slide, we'll spend a little bit of time here. This table summarizes the change in body weight percent that were clinically meaningful as identified by DERP. And I did want to mention that tirzepatide is not approved for weight loss at the time, the publication time of DERP. So one trial was included, but we will discuss the additional randomized controlled trials later in the report. But going through then from the top there, you can see liraglutide, just a general overview. Well, actually, all these agents actually were studied in diabetic as well as non-diabetic populations. Liraglutide was studied most commonly with the primary outcome measured at 56 weeks. They found that the change in body weight percent, there was a mean difference of almost 5%, with a proportion of patients losing at least 5% weight loss was 59% with the number needed to treat. And again, these are all compared to placebo, not in each other. So these are indirect measurements here. So for semaglutide, most often had the primary outcome assessed at week 68. For these patients, the most common BMI was enrolling patients with a 27 to 35. I should mention that was similar for liraglutide, although they did enroll patients with a BMI up to 43. Mean difference from placebo and change in body weight was 11.59%. And you can see there that more patients did lose at least 5% of weight loss with the number needed to treat of 2. And again, the most common dose studied with semaglutide was that 2.4 milligram weekly dose. Tirzepatide, again, this is just the one study. This happened to be done in patients that weren't diabetic with a BMI of 27 to 30 with a mean change in weight loss of 15.37%. And 88% of patients obtaining that 5% more or more of weight loss with a number needed to treat of 2. For naltrexone bupropion, patients with a BMI of 30 to 45, so a higher BMI was studied for these drugs with studies lasting 26 to 56 weeks, a mean change of 4.25% reduction in body weight, and then about 50% of patients obtaining that 5% more or weight loss with a number needed to treat of 4. And then lastly, for phentermine topiramate, these patients enrolled had a BMI of 27 to 45 and were studied for 26 to 108 weeks with a mean difference in body weight percent of around 8.56%. And then 67% of those patients obtaining that 5% weight loss with a number needed to treat of 2. Exenatide was studied for weight loss, but it was compared to glyburide in patients with diabetes. It's not included in this table because it wasn't a placebo comparison, and it wasn't studied against placebo in any of the trials that were included in DIRT. So moving on to the next slide, if we look at youth, we see that patients 10 to 18 years were studied, and liraglutide, semaglutide, exenatide, phentermine topiramate, and setmelanotide were all studied, and they all did demonstrate clinically significant changes in weight loss, with the exception of exenatide. Semaglutide did demonstrate the most weight loss, and this was from one trial in which the BMI percent reduction was 16.7, based on moderate evidence. Excuse me. Moving on to cardiovascular outcomes, we were looking at clinically significant benefits of the weight management drugs, which is really important, and their effect on cardiovascular risk factors such as blood pressure, LDL, and HbA1c. These aren't consistently demonstrated across the board. However, there were some drugs that did show statistically significant benefits, and when compared to placebo, and those for liraglutide, semaglutide, and phentermine topiramate. I would have to say that tirzepatide did show clinically significant decreases in systolic blood pressure as well. And there were statistically and clinically significant decreases in HbA1c in the adult patients that were treated with semaglutide, liraglutide, and naltrexone bupropion. And all these studies did enroll patients with type 2 diabetes. And then in youth 10 to 18 years of age, we did see that semaglutide did also produce clinically significant changes in HbA1c levels compared to placebo. Then moving on to morbidity and mortality, again, conclusive benefit on the reduction in morbidity and mortality has not been established due to this long-term evidence that we have and that was included in the DIRP report. As mentioned, the SELECT trial semaglutide compared to placebo was published after the DIRP report, and we'll touch on it a couple of times throughout the presentation. But this trial did find that there's moderate strength of evidence that semaglutide did reduce that composite outcome of risk of death from cardiovascular causes, non-fatal MI or non-fatal stroke compared to placebo in adult patients that already did have cardiovascular disease and had overweight, so a BMI of 27 kilograms per meter squared or more. We also see that you had to treat 67 people over 3.3 years to prevent one cardiovascular event. So these patients were followed for over 3 years with a number needed to treat of 67. 17% of patients did discontinue semaglutide due to adverse effects compared to 8% of the placebo patients in the trial. Now moving on to safety, just briefly going over adverse events associated with the different drug classes. So for the GLP and the GLP GIP receptor agonists, we see that common adverse events experienced, which is not surprising, were GI related. So things such as nausea and diarrhea. For phentermine and topiramate, it's associated with dizziness, insomnia, dry mouth, increased heart rate. And it also has a REMS for increased risk of embryo-fetal toxicity. For naltrexone bupropion, it is associated with nausea, constipation, insomnia, and vomiting, and also should not be used in those with uncontrolled hypertension or chronic opioid use. One thing that is also often noted with the weight loss drugs is withdrawals due to adverse events that is commonly seen to be higher with placebo, with active treatment compared to placebo. So we see there that was the case for liraglutide, semaglutide, phentermine, combination, bupropion, naltrexone combination, and tirzepatide. And I'd also add at this time that a lot of all of the GLP and GLP-GIP combination products are to be started at low doses and titrated slowly over 18 to 16 weeks, depending on the product and depending on the target maintenance dose to help minimize some of those adverse events. Now kind of moving on to guidelines, that concludes the brief summary of the DIRP report, which is very large, so we didn't include every aspect of it, but one a high-level view. So that concludes the DIRP report, but like I mentioned, there were some good high-quality guidelines that we wanted to include as well. The first one is from NICE, and this is a recent guideline that looked at semaglutide and liraglutide, and they do recommend these for weight management in adults. They have specific criteria based on BMI and comorbidities that they recommend to target the population that would receive the most benefit. And those are outlined on page 171 in your packet if you'd like to take a look at those. They do recommend that pharmacotherapy should be taken in conjunction with the weight management behavioral lifestyle program. And they don't recommend naltrexone bupropion for weight management because there was a lack of long-term data on effectiveness as well as unknown cost effectiveness for this drug. The VA Department of Defense released a guideline in 2020. They found that moderate quality evidence for the use of liraglutide, naltrexone bupropion, orlistat, and phentermine topiramate for weight reduction when compared to placebo. They note that comprehensive lifestyle interventions are strongly recommended for adults with overweight or obesity, and that this pharmacotherapy should be used in conjunction with lifestyle modifications that meet this criteria. And they also have specific BMI specifications and weight-related comorbidity recommendations included in their guideline, which is consistent with the indications for most of these drugs, which is a BMI of 27 to 30 or more. CADTH also released a guideline on semaglutide, and they actually recommended against the use of semaglutide for weight management. This was published prior to the evidence for semaglutide in cardiovascular outcomes based on the SELECT trial. And they cite the reason they're not recommending semaglutide is because there was a lack of data demonstrating prevention or reduction in weight-related comorbidities and lack of clinically meaningful health-related quality of life with semaglutide. The Institute for Clinical and Economic Review also looked at evidence related to weight management, and they provided evidence ratings of the drugs versus placebo. And they looked at semaglutide, liraglutide, phentermine topiramate, and bupropion naltrexone in comparison to the lifestyle interventions. And what they did is they found that there wasn't evidence of benefit based on relatively good evidence for semaglutide and liraglutide, in which they were given a B+ and B rating respectively. And then also evidence to support the use of phentermine topiramate and bupropion naltrexone for weight management as well, but with a lower quality of evidence, a C++ and a C+ rating. The ADA updates their standards of care every year, and in 2024, they did so again. They strongly recommend that adults with overweight or obesity with type 2 diabetes be treated with the GLP-1 RAs or the combination GLP-1 GIP RAs. And the recommendation were to use the drugs with the largest weight reductions, demonstrating the evidence, which at this time is semaglutide and tirzepatide. The American Academy of Pediatrics, the AAP, looked at the treatment of children and adolescents with obesity, and they found that the guidance recommends intensive health and behavior modifications for children and adolescents who have overweight. So for children and adolescents, it's often quantified as percentiles. So a BMI of 85th to 95th percentile for age and sex, or those with obesity, which would be a BMI of 95th or more, 95th percentile or more, or for severely obese, which would be a BMI of 100% or more. And this was all based on a grade B recommendation. They also recommend that providers should offer pharmacotherapy to those children who have obesity, in addition to lifestyle changes for those that are 12 and older, based on a level B recommendation or level B quality evidence. Next, I'd like to look at a new indication. As I mentioned, tirzepatide had received a new indication for the treatment as an adjunct to reduce calorie diet and reduce calorie and increase physical activity for chronic weight management in adults with a BMI of 30 or greater, or those with a BMI of 27 or greater with at least one weight-related comorbidity, such as hypertension, dyslipidemia, type 2 diabetes, obstructive sleep apnea, or cardiovascular disease. 2% of patients discontinue treatment due to tirzepatide adverse events, compared to 1% of placebo-treated patients. This trial, or this indication, was based on a trial that had a large lead-in period, which helps to decrease the adverse events and is lower than what was seen in other trials for diabetes. Okay, then moving on to some randomized clinical trials. These first two trials were done with tirzepatide versus placebo, and these are similar trials, both 72-week trials. The first one looking at 3 different weekly doses of tirzepatide, 5, 10, and 15 milligrams compared to placebo in patients without diabetes. You can see there that they had BMIs of 30 or greater, or 27 or greater with a comorbidity. Both these trials have the same primary endpoint, so it's a co-primary endpoint of percent change in body weight from baseline and body weight reduction of 5% or higher. You can see in the first trial, tirzepatide was superior to placebo, all doses, and that the body weight reduction of 5% or higher was obtained by all doses with a number needed to treat of 2. In the second trial, this trial actually included patients with diabetes as well, same primary endpoint, and that also it demonstrated that tirzepatide was clinically and statistically significant to placebo, with a weight loss of 9.6% to 11.6%, and a number needed to treat of 2 to 3 for those patients obtaining that 5% or more body weight reduction. Moving on, then we look at a third trial with tirzepatide, and this again looked at the 10 and 15 milligram dose compared to placebo over 72 weeks, and found that patients with a BMI of 30 or 27 with comorbidities but without diabetes, who had achieved at least a 5% weight reduction in a 12-week lifestyle program prior to enrollment, were included in the trial. That same co-primary endpoint was evaluated, and they found that the pooled results for tirzepatide versus placebo was that tirzepatide was superior with an 18.4% body weight reduction compared to 2.5 for placebo, and a number needed to treat for the number of patients achieving a 5% more or more weight loss. And then the last trial on this page looked at tirzepatide again, but it was a little different design. It was a 52-week trial in which adults with a BMI of 30 or again 27 and then comorbidities were studied. And they first entered a 36-week open label lead-in period. And then they were followed for 52 weeks. And the primary endpoint was actually that mean percent change in weight from week 36 to 88, who maintained at least 80% of the weight loss obtained during that lead-in period. So tirzepatide was superior to placebo. The mean percent weight loss maintained was 5.5% compared to a weight gain of 14% in the placebo group. Moving then on to a couple more trials, switching gears from tirzepatide to semaglutide orally, 50 milligrams daily versus placebo in a 17-month trial looking at adults with a BMI of 30 or 27 with comorbidities but without diabetes. That same primary endpoint that we've already discussed before, and it found that semaglutide was superior to placebo for change in body weight with a decrease in 12.7%, as well as more patients were able to obtain that body weight reduction of 5% or more with a number needed to treat of 2. And then that last trial, we've already made reference to the SELECT trial in which semaglutide weekly was compared to placebo in adults with cardiovascular disease. So this was a secondary prevention trial, and a BMI of at least 27 or higher with no diabetes. The actual mean BMI of patients enrolled in this trial was 33, mean follow-up of 3.3 years, and they were also on background medications for heart-related indications such as ACE inhibitors, beta blockers, and aspirin. The primary outcome was a composite of death from cardiovascular causes, non-fatal MI, or non-fatal stroke. And you can see that the cardiovascular endpoint was obtained in 6.5% of patients taking semaglutide compared to 8% of those taking placebo, with, again, as I mentioned before, a number needed to treat of 67. And that concludes the review of the evidence, and then we'll get into talking about the proposed PA criteria. Are there any questions at this point?
Great job, Kathy. That's a lot of information. So to the committee, do you have any questions to this point for Kathy on the studies that were included? Kat, go ahead.
Yeah, thanks. This is a great presentation. I have a couple of questions. As a lot of this just is from historical experience with these weight loss drugs, where we saw a number of them that were approved and resulted in weight loss, and the long-term studies found that they were actually increasing cardiovascular morbidity and mortality, for example, with fen-phen. And so I'm just, if you could first just talk about the duration of these studies. And anyway, so a comment about the duration of the studies for all the different subtypes of medications that you talked about would be great, as well as the potential that we might have emerging evidence as we get into 2-year or 4-year studies about potentially harms from some of them. And then I just want to reaffirm that the only cardiovascular outcomes that we have are for a single agent, and we don't have any cardiovascular outcomes for any of the other ones.
Yeah, thanks. That's a great point. Both those are really good questions. Yeah, so the drugs for weight loss have been studied in a variety of different durations. Liraglutide up to 172 weeks, semaglutide up to 120 weeks. The other two, well, naltrexone, bupropion studied 56 weeks, phentermine, topiramate up to 108 weeks. I would say that we do have history with the GLP 1 RAs just because they've been used for diabetes for a longer time period. So I think that we can have a little bit more confidence in those, but I think that's a great point. We don't have cardiovascular outcome data on some of these drugs. We do now have that study with semaglutide that was, a little over 3 years, 3.3 years mean duration. And so that have that evidence that tirzepatide is in ongoing trials right now, as well, looking at cardiovascular outcomes. So I think that's a really great point, really valid point. We have to be careful in that regard. But yeah, I would say at least with the GLP-1s or the dual GLP-1 GIPs, with the study in diabetes, we have a little bit better data, but it is limited far as duration.
Kat, did that address all your questions?
Yes, that was excellent. So only semaglutide has cardiovascular endpoints that are positive.
Right, yeah.
Okay.
That's, I mean, when studied in weight, specifically for weight loss. So for diabetes, that's another conversation, but for weight loss, yeah.
Other questions before we go through some of the proposed criteria?
I have a question. Is that like, does it have like longer duration of follow-up after 10 years? Or like what's the how much they are maintaining weight? And my question also is that GLP-1, especially that like a rebound people are talking about, are there any clear description about that?
Yeah, that's a great question as well. And we're just starting to get evidence in that regard, and no rebound studies were included in the DERP report. However, there is some limited evidence that is coming out that once these therapies are stopped, you do see that you know, the weight gain return. So I think we will continue to see more evidence in that regard.
Thank you.
Mhm.
Other questions for Kathy? So again, as Kathy mentioned, but I just want to reiterate, we do have criteria for explicit coverage for EPSDT. This is the proposed PA criteria for youth. If you're in the packet of materials posted, it's on page 183. So Kathy, I turn it back to you.
Great, thanks. Yeah, so first we're going to look at the PA criteria for youth, and then we'll move on to talking about adults. As Roger mentioned, this is coverage under EPSDT. We have approval authorization there up to 6 months initially. Included a table of improved FDA-approved drugs for adults and pediatrics. And although orlistat was not included in the DERP report, it is actually FDA approved for weight management and in those 12 to 16. So I would suggest that we add that to the table as well. But we can move on to the next slide to get specific criteria. This is a table because, as I mentioned, in children, they're often determined, obesity cutoffs are often determined based on height and weight. And so here's a table just to make that streamlined and easier, and we refer to it in the criteria as well. Looking at number one, we'll just go through these one by one, first asking that standard question of what diagnosis is being treated. Number two is this request for continuation, because we do have renewal criteria we'll go over as well. Number three, is it an FDA approved indication? If yes, then go to 4. Is this a requested medication for patients less than 20 years of age? And I would say 6 years of age and older, just because setmelanotide is approved down to 6. So I would suggest that change there. But yes, then go to 5. Is it for setmelanotide? Yes, and go to 6. I'm not going to read 6 in its entirety, but it's the indication for setmelanotide based on genetic variances. And so, yes, if that's the case, then go to 7. And I should say in number 5, if the request is not for setmelanotide, they do go to 8. So they skip these 2 steps. Number 7, we just ask for those patients requesting setmelanotide if they have a history of depression and are suicidal ideation, because this was reported at a high rate in the studies and is included in the warning and precaution section of the labeling. If yes, then deny it, but if no, then approve setmelanotide for 6 months. Going on to the next slide. Looking at number 8 for those patients requesting other agents, asking if the patient is considered to have obesity or overweight as defined there. Again, with either 30 milligrams per meter squared and higher, or 27 with comorbidities, or if they're at 95th percentile or greater for their age and sex as determined by the table that I just referred to. If yes, then record the BMI and go to number 9. Asking if the patient has comorbidities such as hypertension, dyslipidemia, diabetes. The reason for this is feel like this population may need treatment sooner. So go ahead and go to number 11. If they don't have these comorbidities, then ask for number 10, which asking if they've tried a weight loss treatment plan administered by a healthcare provider for a time period of at least 3 months within the last 6 months and been able to meet target weight. Then they go to number 11. And that clinical notes included, it's on page 186 in your packet. It's not included here in the presentation, but it just goes over some recommendations by the AAP on what things can be tried to help children and adolescents with overweight or obesity. And then, so yes, if they've tried that, then they can go number 11. And then just asking if the patient will be engaged in a weight management lifestyle modification program in addition to pharmacotherapy, as this is recommended in all the labeling of the weight management drugs as well. If that's okay, then to go ahead and improve it for 6 months with the medication supply limited, potentially limited by quantity limits. So I think we'll go over the renewal criteria for youth and then maybe see if there's any questions. We'll tackle the youth before moving on. So for the renewal criteria, just asking them if they've received this medication before. If yes, if they're still 21 years of age or less. If yes, then have they had a reduction of at least 1% in the BMI or maintained at least a 1% reduction in the BMI with pharmacotherapy? If yes, then go to number 4. Asking that the patient be continuing with a weight loss treatment plan, with exercise and reduced calorie diet. If yes, then just asking if the patient's been adherent to therapy based on the provider attestation. If yes, then go ahead and improve it for 6 months.
And just to clarify, this is for members that are less than 21 years of age. And this is not Medicaid rules. This is EPSDT, early periodic screening, diagnosis, and treatment. So it's being covered and we get federal match for that, but we have to follow coverage less than 21 years of age. So if someone aged into 21, coverage for these therapies would no longer be continued because it's not part of the state plan under Medicaid. So I just wanted to add that clarification. And again, make sure that people understood that it was less than 21 years of age for EPSDT.
Thanks for
Any
that.
questions about the criteria? These would be criteria that we're proposing but would be implemented so that when we receive requests, they would be used to adjudicate claims as soon as approved by, proposed by the committee and approved by the OHA.
This is Eddie. I have a question.
Go ahead, Eddie.
And just looking at that renewal criteria and also considering that this criteria is for ages up to 21, is that 1% change from baseline representative of the minimum clinical, or what am I trying to say? Minimum significant benefit for pediatric population or for that whole population? It seems like there might be a need for a difference between the pediatric population and then the 5% weight loss for, older than 18 or 18 and older. Or am I thinking about that incorrectly?
Yeah, that is correct. It's the weight loss determined by AAP that was clinically significant and outlined in DERP of the 1%. Sometimes that goes up to age 20 versus 21, which would fall in with this whole population. I could tease it out specifically for 18 to less than 21 and see if there is any evidence or literature, specific to that. So we could look at that if you'd like. But yeah, it is what's recommended for children and adolescents. But again, that 18 to 20 group, I'd have to look if it specifically states that in the guidelines or not.
Any other questions, or that answer your question today, Eddie?
Yes, that does. Thanks.
You bet. Any other questions on this proposed criteria? And just to clarify, there's a lot of people in the audience, and I know we have 8 people that are wishing to provide public comment today. Just wanted to set the stage for that. We're going to go through some proposed criteria that should the OHA open up coverage that is kind of a straw man for what the coverage would look like. So we're going to be discussing that first, just so we're answering all the committee's questions. We're not, I just want to make sure you understood, for the people that are going to be providing CUBLA, we'll be coming to you shortly and providing you your 3 minutes of opportunity to discuss and provide feedback to the committee as they deliberate. But I just want to set that stage so no one was worried that we're missing out as we talk about these criteria. So Kathy, with that, I'll leave it to you for your next portion.
Great. Yeah, thank you. So moving on to the adults, I'll be presenting the adult PI criteria for weight management to solicit feedback from the P&T committee to help guide the criteria and identify the most appropriate candidates for weight management medications if we were to open up coverage. So these are just draft criteria, again, that we'd love your input on. Looking at this first slide here, the only change again, I would add orlistat to the table, just for completeness. And then going ahead and looking at the criteria, starting on the next page. Again, number 1, 2, 3 is identical. I'm not read those to you. Starting with number 4, again, this is standard language we use in most of the adult criteria. Will the prescriber consider a change to the preferred product? And then if so, yes, we'll inform them of that. If no, then go to number 5. Again, the same criteria as we had for the youth. Is the request for setmelanotide? If yes, go to 6. Again, ensuring that it's of use approved in that appropriate population. If it is, then go ahead and go to number 7. Again, asking about the suicidal ideation and depression. If no, then go ahead and improve that. But for those patients not requesting setmelanotide, to go to number 8, which is asking if the patient has tried a weight loss treatment plans such as diet and exercise within the last 3 months, or for at least 3 months in the last 6 months, and unable to meet weight loss goals. If yes, then again, making sure they qualify as being overweight or obese as designated by the BMI, and overweight with comorbidities, I should add. If yes, then go to number 10. And again, just make sure that they're in some kind of lifestyle modification program. And at the time of opening up coverage, hopefully have some kind of guidance around. I have Medicaid approved, which there's not one currently, but we'd also really like to get the committee's help in this regard on what they might consider would be an appropriate diet or lifestyle requirement. Because again, in all the labeling, the pharmacotherapy is indicated as an adjunct to these lifestyle changes. So, but if yes, they are in a approved lifestyle modification program, then go ahead and improve it up to 6 months. And we do have renewal criteria for the adult population as well. So if we look at that, starting in number 1, again, just making sure they've received one of these pharmacotherapies before. And then 2, asking for that BMI change of at least 5% or maintenance of that. And if yes, then asking if this is a continuation of therapy without a lapse in treatment. Because of tolerance, sometimes individuals go on and off these therapies. And so just want to make sure that if that is the case, they've had a lapse, then in number 4, that they be seen by a specialist. If they are requesting an additional trial of the same or different weight loss drug within the last 2 years, just make sure that they're being overseen appropriately. So if yes, then go ahead to number 5, which again, just asking that the patient's continuing with a weight loss treatment plan that includes diet and exercise and has also been adherent to their therapy. And if so, then I go ahead and approve it for 12 months. So as I mentioned, yeah, if there is any questions or if anyone has any recommendations for diet and physical exercise requirements or thoughts on that, that would be helpful as well.
Hi, Kathy. I have a question. One of the issues we're facing right now is the significant manufacturer and wholesaler, shortages that is affecting patients' abilities to not have lapses in their treatment. They intend to continue on the treatment, but aren't able to actually get their refills. And so I wonder how this renewal criteria would treat those situations. Would those be considered lapse in treatment if someone, has gone weeks or a month or so without being able to get a refill, if that would be considered a lapse?
That is a great question, Eddie. And before we address it, I think in these proposed criteria, because again, this is something that the OHA is going to be considering. They're going to be looking at budgetary impacts, and it would not be, and it would require a change to our state plan before we got there. So we're looking at, again, 2026 or something like that before the coverage. I think your question is pertinent. I don't know that we want to spend the time trying to boil that into these proposed criteria as we get closer to assuming we will have coverage and having criteria. I think that's something that one would bake into those. But I think it's a great question for some of the people that are providing public comment today. So both the lifestyle modifications, dietary requirements, and if any of the manufacturers who've signed to provide testimony can speak to the shortages, I think that would be illuminating for the committee. Does that kind of skirt around your question, but let us not focus on that with these criteria?
Yes, thanks.
But still entertain it. All right. Other questions for Kathy on these proposed criteria should the OHA elect to open up coverage? Kathy, anything else before we start with the public comment?
I don't think so, unless you want me, I can recap the recommendations after public comment. Would that be preferred?
Yeah, I think let's do that. But for now, so I do have 8 people that have signed up for public comment. We're going to start with Rieger Cortell, FNP. She's the director of the Southern Oregon Bariatric Center. I've made you a co-host. So you should be able to unmute your line.
I think I'm
on
here.
deck. Yep. Hold on for 1 second. Let me just set the stage. On deck, we have Leslie Ann Hayward Story, doctor out of OHSU. So not your turn yet, but let you know. So as we work through the people providing public comment, you'll be given up to 3 minutes to address the committee. So go ahead. I will have a timer on glaring in front of you. I don't know if you're able to see that.
Yep, great.
Okay. So you have 3 minutes. Take the time to address the comments that you wish. We'll leave time after the time expires or you're done with your comments to let the committee have any questions for you, and that won't go against this time. So again, won't be didactic and question and answer as we go through this. So with that, the floor is yours.
Thank you for the opportunity to speak. My name is Rieger Cortell. I'm a family nurse practitioner in Medford, Oregon, specializing in adult obesity medicine and bariatric surgery at Southern Oregon Bariatric Center for the past 15 years. I'm here definitely to advocate for FDA-approved anti-obesity medications as a covered benefit for Oregon Medicaid recipients. These medications have proven effectiveness. I can attest that they significantly enhance the treatment of obesity, much like other chronic diseases are benefit from proven medications. I'd like to introduce you to a typical patient I see. It's an adult in their 40s or 50s, navigating the complexity of life, work, family, and the natural changes that come with aging, all while carrying the burden of obesity since their younger years. Despite their many efforts with diet and exercise and various weight loss programs, success has been elusive, leaving them feeling defeated and frustrated, all while their associated diseases worsen. As part of my assessment, I always review the patient's nutrition, physical activity, and behaviors which support weight loss and weight loss maintenance. Based on my assessment, I make recommendations accordingly, and together we come up with a comprehensive evidence-based treatment plan. To speak to that briefly, I am aware that an approved lifestyle modification program for adults is yet to be determined by this committee. To that end, I recommend the committee turn to the Obesity Medicine Association for guidance, as their evidence-based guidelines are invaluable in directing patient care. Ideally, when coverage allows, I would start this patient on one of the FDA-approved anti-obesity medications at their first visit. The results are often remarkable: reduced hunger, fewer cravings, weight loss that aligns with the clinical studies. Equally important, these patients report renewed hope, which reinforces their commitment to continue. We then schedule regular follow-up visits, just like managing any other chronic disease. This is standard of care. I would love to offer the same level of care to Oregon Medicaid recipients starting at visit 1, which brings up an important point. Approval criteria number 8 for adults recommends denial of access to anti-obesity medications if it cannot be proven that the patient has tried a weight loss treatment plan over the last 3 months duration within the past 6 months and has been unable to meet weight loss goals. This requirement, while well-intentioned, ignores the reality that the majority of patients who seek treatment for their obesity have years of weight loss efforts behind them, but very little proof because, as we all know, the treatment of obesity has been relegated to commercial industry due to the lack of recognition and coverage of obesity as a chronic disease. Asking them to undergo more delays to prove the severity of their disease is unnecessary and unhelpful. In conclusion, I urge this committee to not only approve the inclusion of FDA-approved anti-obesity medications as a covered benefit for Medicaid recipients, but also to set a national example of compassionate, effective, and timely care for those affected by obesity. Thank you for your time.
Thank you for your comments. Questions from the committee for Director Cortell? I think you've given some good things to think about as far as how we should address or investigate lifestyle modifications and dietary modifications. Again, committee, any questions? All right. Director Cortell, well, I know we have your contact information as we progress through this journey. I hope you don't mind me reaching out as needed just to engage you. So thank you for your time.
No problem.
Next we
Thank
have,
you.
Yeah, thank you. Leslie Ann Hayward Story, doctor at OHSU. Are you able to unmute your line?
I think I'm unmuted. Can you hear me?
Hear you loud and clear, and the floor is yours.
Excellent. Hello, my name is Leslie Ann Hayward Story. I'm a board certified endocrinologist in obesity medicine practice, and I practice at OHSU. Thank you for this timely review and for the opportunity to comment. As you know, obesity affects up to 80% of the population in the US and contributes to over 200 medical conditions. Access to FDA-approved anti-obesity medications is crucial, especially for vulnerable groups such as those facing healthcare inequities. I did want to address the following points. One, that obesity should be recognized as a chronic disease and treated as such, similar to other chronic diseases like diabetes and hypertension, and that it's imperative to use person-first language when discussing obesity to reduce stigma. Two, there's need for precision and accuracy. When summarizing the outcomes of weight loss drugs, we should be precise and accurate, distinguishing between different medications and their effects. Not all drugs yield the same results, and improvement in cardiovascular risk with weight loss should be considered. Regarding the considerations for approval criteria, prescription limitations and requirements for lifestyle modification programs may hinder access to medications for those in need. And any licensed practitioner with experience should be able to prescribe anti-obesity medications to lower the barriers for patients to have access. Regarding the renewal criteria and treatment efficacy, stopping rules for weight loss medication should be flexible and allow providers to consider individual needs to allow us to be able to assess the treatment and the response. Sometimes just stopping weight gain can be a success. So having that 5% weight loss criteria could actually hurt someone's progress in weight loss, as other medications could be considered in addition to lifestyle modification. But providers should be given autonomy to determine the most effective treatment approach as they're one-on-one with the patient. In conclusion, removing barriers to access for Medicaid patients to anti-obesity medications is essential for improving health outcomes and reducing healthcare costs. Addressing obesity as a chronic disease with effective medical therapy can significantly benefit vulnerable populations and mitigate the burden of obesity-related complications. Thank you so much for your time.
Thank you, Dr. Hayward Story. Questions from the committee for you? All right. Again, appreciate your time. Next, we have Annie Griffin. I think I identified as you signed in. And on deck is Yolanda Clay. But at this time, Annie, are you able to unmute your line?
Yes, can you hear me?
Can hear you loud and clear and see your emoji, or I don't know what you call that. I'm a boomer, so. But the floor is yours for 3 minutes, so please.
Thank you all for doing what you do. I'm going to try to do this quickly. I've written it down so I wouldn't ramble. I'm Anne Griffin, a 64-year-old woman with national titles in racquetball, squash, snowboard, and halfpipe. I'm an addict. I have a disease. I quit smoking 38 years ago. I'm 37 years clean and sober and very active in 12-step programs. Since the pandemic lockdown 4 years ago, I lost my jobs. I'm on food stamps and Medicaid. I gained 90 pounds. I became stagnant from sofa spud, or turbo. I was overly active prior to lockdown. I taught kids racquetball for 8 years, would randomly swim 30 miles in 30 days, rode my bike around for transportation, and probably averaged 2 to 3 hours of exercise a day at 60. At 60, lockdown stopped all of that. I no longer volunteer in treatment centers or in the downtown theaters. And as a woman in addiction recovery for 37 years, I have begged and begged OHP, Care Oregon, in tears as I am now for the last 2 years, to help pay for the two things I know that would help me. Either a 30-day treatment center where my behaviors would be able to be changed out of my apartment. Any 12-step one would do. Addiction is addiction. If you have it, you know it. It travels. Or a weight loss drug like Wegovy or Zepbound. I have never needed nor used a lot of my health insurance, knock on wood, because I've been healthy. Now that I'm not healthy, I'm denied the money for the health care I need. Please, I am an addict begging for help, again, in a public forum. Please, Oregon Health Plan. Please, OHA. Please, I tried to get into one of your things down at OS, but I live in Portland. So please let me have a weight loss drug that's paid for. I've already gotten the prescription. You can get that at Costco now, for God's sakes, so that I can fully live again. I personally need help so that I can become active again. I will die soon. My dad died at 46 and my mom died at 75, 20 years ago today. So I'm here to honor her and me and the life that I had, which I know my lifestyle will be more active should I be able to lose weight first and foremost. Thank you all for what you do.
Thank you, Ms. Griffin. I appreciate it. Does the committee have any questions? All right, again, thank you for taking the time to come and provide comment for the committee to consider as they deliberate. Next, we have Yolanda Clay. Are you able, and on deck,
Yes, I am.
Crystal Hartman. So Yolanda, again, doesn't have any, hasn't been asked to attend here by the pharmaceutical industry, is part of advocacy, is part of the Obesity Action Coalition, and asked them to be a patient advocate. On deck, we have Crystal Hartman. So I will make you a co-host in just a moment, but Yolanda, are you able to unmute?
Yes, can you hear me? Can you hear me?
You bet. Hear you loud and clear.
All right.
And the floor is yours.
Thank you for this opportunity, for letting me share my story about my my living with chronic obesity. Chronic obesity is a complex disease, and science has proven that it's more than just calories in and calories out, or a lack of willpower. In 2013, the American Medical Association officially declared obesity a disease, but society still treats people affected differently than other diseases. In the 90s, I worked long hours in a physically demanding job as a nursing assistant, while also attempting to use food as medicine to stop the progression of this disease. None of these interventions worked for me. The treatment options of monitoring my calories and increased physical activity were not successful in treating the disease of chronic obesity. In 2004, I weighed 320 pounds, and I had internalized much of society's negative biases. I began a low-carb diet, and I lost 100 pounds. But after 9 months, I began experiencing side effects, and the restrictiveness of it was wearing on me. I sought advice from my doctor, and she told me to eat a banana. So I went home and ate that banana. I gained 5 pounds overnight, and it seemed like my body was absorbing calories triple time. I gained all of my weight back and plus some. In my 40s, I reached my highest weight ever, 410 pounds. My doctor referred me to a bariatric surgeon, and I had sleeve gastrectomy surgery. With hard work and surgery, I got down to 249 pounds, but I still struggled with keeping my weight off. Last year, I was able to add Ozempic to my treatment plan and lost over 30 pounds. In April of 2023, I had bariatric revision surgery due to severe GERD, but my surgeon explained that this surgery was not for weight loss. I only started to reduce again after restarting Ozempic. As a Medicare and Medicaid beneficiary, I'm afraid all of my momentum to create positive health gains will cease because my insurance company will no longer cover Ozempic for me. I cannot afford the $1,300 out-of-pocket cost per month. My overall health improved on Ozempic, my mental health, A1C, and even with the A1C getting better, it means that I can no longer have the Ozempic in order to improve my outcome with the chronic disease of obesity. Oregon ranked 39th in the state impacted by obesity. This makes the need for expanded access to care even more urgent. Oregon has a history of paving first in this nation. Please let expanding anti-obesity medication coverage for all to be another. Thank you.
Thank you, Ms. Clay. Any questions from the committee? Again, appreciate you taking the time to provide your testimony today for the committee's deliberation. Next up, Crystal Hartman, you're going to be having the floor in just a minute, and I want to say that Kat Kachatourian from Novo Nordisk, you are on deck. So Crystal, are you able to unmute your line?
Yes, can you hear me?
Yes, we can. You're a little soft-spoken. If you can speak up just a little bit.
Oh, yep. Okay. I'll make sure to speak louder.
Nope, that sounds great right there. Just want to make sure that we can hear you loud and clear, and the floor is yours.
Great. Thank you so much. My name is Crystal Hartman, and I am a person living with the chronic disease of obesity. I am a proud member of the Obesity Action Coalition. There are 1,000 members in the state of Oregon and over 85,000 members across the nation. We are a nonprofit organization that represents patients and people living with the chronic disease of obesity. I am here today because I am also a Medicaid patient. My children and I are on Oregon Health Plan. And I also am proud to serve as the National Board of Directors chairwoman of the Obesity Action Coalition. So I'm really here as a patient to describe what it's been like for me and the first 20 years of, age 14 to 34, what it was like living with the chronic disease of obesity. And I believe that our disease is actually treated differently than other chronic diseases like diabetes and heart disease and high blood pressure because of years and years of weight stigma and weight bias. For those first 20 years of me experiencing obesity, age 14 to age 34, I was just told by my primary care physician if I would just put the fork down and take a walk around the block, that I would be able to cure my obesity. After all, this is my fault and I did it to myself. And we all know that that is not the truth. And certainly at age 34, I found myself on 14 medications for comorbidities of obesity. And I was sicker than I ever had been in my whole life and had several hospitalizations due to those comorbidities. At that point in time, I had bariatric surgery. and was able to lose 100 pounds. My BMI when I had bariatric surgery was 42, which we used to call morbid obesity. Thank goodness we have changed that vernacular to severe obesity. As time went on, though, in the past 10 years since my bariatric surgery, I experienced weight gain. And I have been on a GLP-1, and that GLP-1 actually is at a diabetes dose because I still have severe issues with some of the other comorbidities of obesity. And certainly when I just a few months ago found myself having to go off of my medication for my colonoscopy, I gained 12 pounds in 2 weeks because that food noise came back to me tenfold and I couldn't stop obsessing about food. So GLP-1s have been an important part of my treatment. I've been hard pressed to be able to lose that weight. I am now into the overweight category. And if I could get a GLP-1 at an obesity dose, I would be able to get back down to my normal BMI. So I really urge the committee to please consider covering these medications for adults on Medicaid. Thank you so much.
Thank you very much, Ms. Hartman. Any questions from the committee? Again, thank you for taking the time to provide your testimony for the committee's deliberation today.
Yeah, happy to.
You bet. Next up, we're going to have Dr. Kat Khatchatorian, PharmD with Novo Nordisk. And then on deck, we have Josh Akers with Eli Lilly. So, Kat, are you able to unmute your line?
I am. Are you able to hear me?
You bet. Loud and clear, and the floor is yours.
Great, thank you. Hello, my name is Kat Khatchatorian. I'm a pharmacist and work as a medical account associate director with Novo Nordisk. Before jumping into the evidence for weight management, I want to remind the committee that glucagon-like peptide, or GLP-1, is the naturally occurring hormone in all of our bodies that helps to regulate several biological processes. The first GLP-1 receptor agonist was FDA approved in 2005. The semaglutide GLP-1 molecule was approved for use in diabetes in 2017, gained a cardiovascular indication in patients with diabetes in 2020, and was approved in 2021 for weight management under the brand name Wegovy. These timelines are important when considering the duration of exposure to GLP-1 medications that comprise part of the general discussion. Just wanted to address several of those comments that were raised by committee today. As we're here to discuss weight management specifically, I will proceed with my ask. I want to thank you for opening up the conversation around obesity management and add comments regarding the use of the anti-obesity medications. I would like the committee specifically to request that they endorse coverage of semaglutide injection 2.4 milligrams, brand name Wegovy, and pursue a funding plan for the treatment of pediatric and adult patients with overweight or obesity. Further, as discussed with the SELECT label, the SELECT study, I would like to make the committee aware of the updated Wegovy label granted by the FDA on March 8th, 2024, as a result of the SELECT data included in the meeting packet. The efficacy and safety of Wegovy were originally studied in the multinational multi-trial STEP program, which led to the FDA approval in 2021. In 2024, Wegovy became the first weight management medication to also be approved in combination with reduced calorie diet and increased physical activity to help reduce the risk of major adverse cardiovascular events in adults with cardiovascular disease and overweight or obesity. The cardiovascular indication was granted as a result of a multinational, multi-center, placebo-controlled double-blind trial already mentioned by the committee known as SELECT. This randomly assigned more than 17,600 participants to receive either Wegovy or placebo. Participants in both groups also received standard of care medical treatment, such as management of blood pressure, cholesterol, healthy lifestyle counseling. In SELECT, Wegovy significantly reduced the risk of MACE by 20% compared to placebo. Additional secondary endpoints in SELECT demonstrated significant improvement in body weight, waist circumference, glycemic status, and important cardiovascular biomarkers, including lipid levels, blood pressure, C-reactive protein among Wegovy-treated patients compared to placebo. The most common adverse effects of Wegovy were GI in nature, include nausea, vomiting, and diarrhea. I'd be happy to send the committee further information. And with regard to shortages asked by the committee, Novo Nordisk has made meaningful commitments to expand and increase ability to meet increasing demand of GLP-1 medications and reduce the impact of shortages on patient access to necessary care. Thank you so much for your time today.
Appreciate that, Dr. Khachatorian. So again, are there two things I just wanted to point out? You talked about coverage for kids. That is what we discussed about with the EPSDT, so there would be a pathway today. You also talked about the new indication, and as Dee tried to tee up at the beginning of the conversation, that isn't, with the new indication, it isn't the treatment of obesity. And so there would be a pathway, but we are explicitly going to be looking at bringing back some dedicated criteria to the June meeting. Make sure that you're listed on our website so you see when we post draft materials. That is the best time for you to provide feedback, valuable feedback for my authors to consider as we develop, information, criteria, the reviews. And then when we post those 30 days in advance, we don't change them. But again, I appreciate your comments, and really there'll be an opportunity coming up for you. So with that, let me see if the committee has any questions for you. Okay, hearing none. Again, thank you for your time. Josh, I've made you a co-host. On deck, we have Cody Gerber with Rhythm Pharmaceuticals. Josh, are you able to unmute your line?
I am unmuted.
Sound loud and clear. The floor is yours.
Great. Thank you very much for the time today. Good afternoon, everyone. My name is Josh Akers, and I'm a pharmacist and an outcomes liaison with Eli Lilly. I appreciate the thorough review on the data and the approach that the committee is taking in the review of this class. I would like to address just the comments about the shortage. Demand for tirzepatide continues to be unprecedented, reflecting the critical needs of people living with diabetes and obesity. Lilly is moving with purpose and urgency to ensure our innovations are available to those who need them. While Lilly continues to manufacture and ship all doses of Zepbound and Mounjaro, due to the unprecedented demand for these medicines, some patients may experience difficulty when trying to fill their prescription at their pharmacy. We recognize this situation may cause a disruption in people's treatment regimens. Given the local and regional supply chain dynamics, patients having trouble obtaining their medicine at one pharmacy may try others in their area. Alternatively, if someone continues to experience difficulty obtaining their medicine, they can contact their healthcare provider who can assist with their treatment plan. We are in regular contact with the FDA to provide updates on supply, and they will follow their process to update the drug shortages database. At this time, I have nothing further to add to the review that has been done by the committee, but I am available for any questions on tirzepatide. Otherwise, I will yield my time back to the committee.
Appreciate that, Josh. Any questions for Josh? All right, appreciate the updates on the availability. I think that's a burning question too as we consider this. Next, we have Cody Gerber. Cody, I see you on my screen with Rhythm Pharmaceuticals, the manufacturer of Imcivree. The floor is yours if you can unmute.
All right, thank you, Roger. Can you hear me?
You bet, loud and clear.
All right, thank you very much. And thank you to the rest of the committee members for your time today. My name is Cody Gerber, and I'm a pharmacist with Rhythm Pharmaceuticals North American Medical Affairs. I'm here to discuss Imcivree, or setmelanotide for injection, which is a first-in-class treatment for rare MC4R pathway diseases of obesity, initially approved by the FDA in November of 2020 for chronic weight management in adult and pediatric patients 6 years of age and older with obesity due to POMC, PCSK1, or leptin receptor deficiency. The FDA also approved Imcivree in June of 2022 for the chronic weight management in adult and pediatric patients 6 years of age and older with obesity due to Bardet-Biedl syndrome. And Imcivree is not indicated for other types of obesity, including general obesity. Reviewing the criteria today, I just have one proposal for a change to the PA criteria. While the approval criteria is certainly aligned to the correct FDA indications that are found in the Imcivree's prescribing information, I do propose a change to the surrounding the recommended monitoring of efficacy. Per our current Imcivree FDA approved label, when looking at obesity due to POMC, PCSK1, or leptin receptor deficiency, it's recommended that weight be evaluated after 16 weeks of treatment. If a patient has not lost at least 5% of their baseline body weight or 5% of their baseline BMI for patients with continued growth potential, it's recommended that Imcivree be discontinued, as it's unlikely that the patient will achieve or sustain clinically meaningful weight loss with continued treatment. Now, this is in contrast to obesity secondary to a clinical diagnosis of BBS, where the current FDA-approved label for IMCIVREE recommends evaluating weight loss after 1 year of treatment. If a patient has not lost at least 5% of baseline body weight or 5% of baseline BMI for patients aged less than 18 years, discontinue IMCIVREE as it is unlikely that the patient will achieve and sustain clinically meaningful weight loss with continued treatment. That is my only suggested proposed change to the current PA criteria, and I'll yield back the rest of my time.
Appreciate that, Cody. Any questions for Cody or any questions specifically about IMCIVREE from the committee? Okay. Again, thank you for your time and providing the testimony, Cody. So I'm going to turn it back over to Kathy Centena, and we will recap the recommendations that are in front of the committee and see if you want to discuss and deliberate on both the EPSDT criteria and the proposed adult criteria for consideration by the OHA.
Thanks, Roger. Yeah, so the recommendations would be to recommend that the OHA performs a budgetary analysis and identify a funding plan to consider opening coverage for weight management drugs, to implement the proposed PA changes for coverage under EPSDT, and then thirdly, establish clinically appropriate minimum standards for required diet and lifestyle modifications. I did look briefly into what Eddie had mentioned regarding the decrease in BMI based on age. The studies included in AAP were up to 18 years of age. However, WHO and the FDA, all and the American Academy of Pediatricians, they all define adolescents up to 20 years. And so anyways, I can take any comments or look into that further if we want to change that, as well as any other changes based on public comment that the committee wants to apply. So for the, I guess for the youth criteria for renewal, for the current request is that they lose at least 1% BMI for anybody under the age of 21. So I guess my question is, do we want to change that or look into it further or keep it as is?
Thanks for looking into that, Kathy. This is Eddie. I don't have any further recommendations based on what you said.
Okay.
All right, so the three recommendations are in front of the committee. We can take them individually, or if we have a motion to approve all three, are to that the OHA can perform the budgetary analysis to identify a funding plan and consider opening coverage broadly for weight management drugs, to implement that proposed PA criteria for under EPSDT, and to establish clinically appropriate minimum standards for diet and lifestyle modifications. Certainly that would be ongoing in response to the OHA opening coverage or considering that. Do we have a discussion or a motion to approve?
I just wanted to add, it sounds like the clinically appropriate minimum standards will be further elucidated. The diabetes prevention program has excellent evidence. It is a covered OHP benefit, and so participation in DPP could be certainly be one of those minimum standards.
Great feedback. So again, specifically to the minimum standards for diet and exercise or my lifestyle modification.
Parenthetically, and at Umpqua Health Alliance, and we've had 2.5 year experience with registered dietitian intervention via telehealth, which addresses a lot of the rurality problems that are brought up continuously in this arena, and we have utilized that as a minimum standard by engagement in that program.
It's good feedback, Doug.
I'm sorry, just for clarification, this is for both adult and the pediatric.
So the pediatric is criteria that we would implement immediately and be using to adjudicate requests under EPSDT. The adult coverage this is the first step to get the OHA to start to look at what this impact might be. And there would be a cascade of events should you recommend this, that the OHA would look at what does this cost? Do we have the budgetary needs? And pursue requesting CMS approve a change to the state plan to open this optional benefit.
Thank you.
Did that answer your question, Noriko?
Yes, and yes.
Okay.
I think so. I think I understood.
Okay.
This is Eddie. I have another question. To the comment that was raised earlier about criteria, I think it was number 10, in terms of the need to demonstrate previous lifestyle modifications. It sounds like the FDA approvals, have a clear recommendation that these medications be prescribed in alongside diet and exercise. I'm wondering if it would be sufficient to only have criteria 11, right? To have as long as the patient's engaged in a modification program, lifestyle modification program, is that sufficient to meet the evidence based recommendations in that regard, rather than requiring evidence prior to approval?
I think definitely the OHA can take that under advisement. Again, these criteria are not final or would not be filed in rule and going into implementation, right? This is just trying to lay out a straw man so the OHA has an understanding about how do they model what patient population may be availing themselves of this therapy if coverage is opened. And so I think it would be hard to quantify that even if question 10 were there or weren't there. And so I appreciate the comments that, encourage you to look at that from Director Cortell. So I don't think we have to make a hard and fast decision about these criteria, like they're approved or not. It's mostly the concept. Do you recommend the OHA definitely look at opening up coverage for these medications? And we would come back to these criteria eventually if we get to that point where we're opening coverage and need to have specific dedicated criteria.
Gotcha. Thanks for the clarification.
Yeah, you bet.
And I guess to add on that, Roger, that same question is in the criteria for youth.
A good point.
So, I mean, I guess it's still valid. I do think that, as we heard in public comment, people have tried lots of stuff previously and not all of it's documented. And so what level of documentation would the committee want before authorizing use of these drugs, I think is a good question.
Well, I, for one, would, I would like to have, I think that we do have to have documentation of an established program, not whatever Snapchat or Instagram diet that someone wants to get on, and has claimed to follow. In other words, and most, the bariatric surgeons are generally making sure that they have success after their surgeries. And so they institute these changes and have the patients demonstrate this before they start. These medications are assumed to be, lifetime medicine. So it's a big deal to make this choice. And the last thing we want to do is provide a message that, a prescription and we'll take care of everything, and that there aren't other accompanying requirements for you to be successful. So anyway, I think the number 10 and number 11 are very appropriate. So I would move to approve these criteria for our use for EPSDT.
Appreciate the comments, Doug. Other committee members? Eddie, I'm hearing you think that we should remove question 10 from the EPSDT proposed criteria.
I was just raising the question for discussion.
I appreciate that. I don't want to put you on the spot. Sorry. Other comments? We do have a motion to approve the proposed criteria for EPSDT as drafted.
Roger, this is Erica again. I just want to make sure that if I approve or agree, this is basically to move forward for the Medicaid, Medicare to start covering for this medication, right? This is
So great question. So again, this is just for Medicaid. Medicare is
Medicaid, sorry.
independent, right? No worries. And these criteria would be implemented immediately for youth, people that are less than 21 years of age. We need to consider requests under EPSDT, and these criteria would go in for that. We already have entertained and have approved requests, but we haven't had specific criteria that delineate what is medically appropriate and medically necessary. This would serve that purpose immediately. The proposed adult criteria are the ones that would be kind of a placeholder and start to set the stage for the OHA to consider what this would look like for them to open coverage, to request their state plan being changed, and what it might cost them. So the budgetary impacts if they need to go to the legislature, what would be needed to change the benefit. Does that make sense?
Yes. Thank you.
Okay. You bet. So again, we have a motion. So the recommendations that are to the OHA perform the budgetary analysis and identify a funding plan to consider opening coverage for weight management drugs. So that would be for adults. To also implement the proposed criteria that we have sent here under EPSDT as drafted. And then we would establish clinically appropriate minimum standards for required diet and lifestyle modification. So again, I think we've got some good recommendations about areas to look for good evidence and recommendations. So Doug, I heard you recommend we implement the criteria, but can I?
I'd like to second Doug's motion.
Okay, and so is that for all three to
That's
OHA to
correct.
consider opening? You bet. Okay. All those in favor?
Aye.
Aye.
Aye. Aye.
Aye.
Anybody opposed? Any abstentions? Great. Thank you for the robust discussion. Thank you too for all the people that signed up to provide public comment, your patience in providing that for the committee to deliberate. So it's 3 o'clock. I propose we do one more topic because Deanna has a couple on the agenda. Let's get one of hers done, and then we'll take a 10-minute break if that meets the committee's bladder holding ability, maybe. So with that, if you're following along in the packet, we'll turn your attention to page 192. And Deanna, turn it over to you for one before the break.
Perfect. If we could go to the next slide, please. So the purpose of this drug class review is to look at drugs that are used to cleanse the bowel prior to diagnostic or therapeutic colonoscopy. Currently, we do not have a preferred drug list with these drugs in that. So the purpose of this review was to provide the evidence to help us identify what should be preferred and non-preferred based on safety and efficacy. Next slide, please. I just kind of summarized the different FDA approved products that are available. If you look on page 196 of the packet, there's a lot more in-depth detail about all of these drugs, but basically, the gold standard, of course, is the polyethylene glycol electrolyte lavage solutions, or Go Lightly. Then we have another one that had ascorbic acid that was added to it, and that was added mostly to enhance palatability. The issue with that is if people have a glucose 6-phosphate dehydrogenase deficiency, the ascorbic acid can't be metabolized, so it's contraindicated in those patients. Then we also have PEG 3350, which is an over-the-counter product, and not OTC products don't undergo FDA approval, so it does not have the indication to use for colonoscopy prep, although some gastroenterologists do recommend using the over-the-counter Miralax. And then finally, we have a number of saline-based laxatives. They have different salt, magnesium, potassium, and you can see on that table the different types. So the brand names are Suprep, Clenpic, and Sutab. So if we could go to the next slide, please. So there were 6 systematic reviews that have been published looking at different routes of administration, different dosing regimens. The first one looked at split dose regimens versus single dose administration. And by split dose, it means they get half of the dose the evening before the colonoscopy and then the rest of the dose the morning of. And the split dose regimen seems to do a better job at helping the gastroenterologist detect adenomas, either the ones that are just developing or even the advanced adenomas versus giving the single dose administration. Then the next systematic review looked at looking at the very high volume, so more than 2 liters versus low volume, less than 2 liter PEG products. And they didn't find any difference in the adequacy of bowel cleansing. You can see they had 86 versus 87.4%. So what they did find, you know, we're looking at the adequacy of bowel cleansing. That's the quality measure, but the low volume products did seem to have better odds for patient adherence of completing the regimen, and then less adverse effects such as bloating, nausea, and vomiting. Next slide, please. Then there's some ultra low volume products. A lot of those are the ones that are saline based, or the 1 liter polyethylene glycol with ascorbic acid. And then also, if you may remember, Fleet's phosphosoda used to be on the market. It has been taken off the market because of adverse events associated with that sodium phosphate product. So in the ultra low volume, the bowel cleansing varied from 75% to 92%. And although the low volume products were effective, it did not always meet the 90% quality standard that was defined by the European Society of Gastroendoscopy guidelines that were published in 2017. So the only one that really met that 92% was the sodium sulfate 354 ml product. Then there was another systematic review that looked at using 1 liter of the polyethylene glycol with ascorbic acid versus other products, which included a 2 liter PEG product with ascorbic acid, 4 liter PEG, and then trisulfite products. And it showed that the 1 liter PEG had a higher bowel cleansing rate compared to the other preparations. And that was based on 9 randomized controlled trials. We can go to the next slide, please. The last 2 systematic reviews, so there's a sodium picosulfate magnesium citrate product, abbreviated SPMC, that came to the market in the early 2000s, I believe. And they were comparing that with PEG-based regimens and showed that adequate bowel preparation favored the PEG product. There was no difference in adenoma detection rate. And there were less adverse effects with the sodium magnesium citrate product. And then the final systematic review looked at efficacy of oral sulfate versus PEG-based solutions. And that analysis suggested that the oral sulfate solutions increased the polyp detection rate compared to the PEG-based laxatives. And that the adenoma detection rate was higher with the sulfates compared with the PEG-based laxatives. So let's go into the guidelines. So in 2014, there was a multi-society guidance put together by 3 different agencies in the United States. And based on the evidence at that time in 2014, they strongly recommended using the split dose bowel cleansing recommendation. Although they did go on to say that if people are undergoing an afternoon colonoscopy, that perhaps the same-day regimen might be better for those folks to do that in the morning before the colonoscopy. They do recommend that the second dose of the split dose preparation be started 4 to 6 hours before the colonoscopy, and make sure that that is completed at least 2 hours before the procedure. And then finally, they did not recommend one product over the other. At that time, mostly it was the PEG products that were on the market. They did say, though, that the selection should take into consideration the patient's medical history, any other medications, and if they had had a colonoscopy before, how well that bowel prep had been cleansed, or how effective that was in cleansing the bowel from the prior colonoscopy. Next slide, please. So in 2019, the European Society came up with guidance that was very similar to the United States. They did recommend using either high volume or low volume PEG-based regimens, or the non-PEG-based agents. Again, if patients were at risk for electrolyte disturbances, then the choice of laxative should be individualized. Again, they recommended against using sodium phosphate because it had been taken off the market in the States by then, I believe. And then if patients had inflammatory bowel disease, they recommended sticking with the PEG-based regimens and not using the saline regimens. Next slide, please. So these are the recommendations, are to create a PDL class entitled bowel preparations and include all the PEG products and the saline laxatives that are FDA approved for colonoscopy in this class, and to make at least one PEG product and one saline product preferred on the PDL. Since there's really no differences, we thought it would be best to make those decisions based on costs. So we'll evaluate the drug costs in executive session. And with that, I will open it up to any questions from the committee.
Nice job, Deanna. We do not have any public comment. Any questions from the committee for Deanna? Hearing none. Again, the recommendations are to add the bowel prep class to the PDL and make at least one PEG product and one saline laxative preferred, and we'll evaluate costs in executive session. Do we have a motion to approve?
So moved.
Thank you, Doug.
I'll second.
Thank you, Tim. All those in favor?
Aye.
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 Anyone opposed? Any abstentions? Okay. With that, it's 3:10. Let's take a 10-minute break. I will set my timer on the clock if that works for everybody, and then we'll reconvene and see if we can make it through the rest of the agenda. So make sure I've got the right screen. Share. All right. Thank you, and we'll be back shortly. Okay, we are back in open session. The meeting is being recorded again. Deanna, see you on the screen, and we're going to leave it in your court. So if you're following along on the packet of materials posted on our website, draw your attention to page 218. We have the antivirals for SARS-CoV. So Deanna?
Thanks, Roger.
The floor is yours.
Thank you. I will just remind everybody that this topic was on the February agenda, and due to time constraints, we pushed it back to April. So if you're wondering why it was in the packet yet again in April, it's because we weren't able to discuss it in February. Next slide, please. So we were doing this drug class review just to evaluate the safety and effectiveness for the 3 antivirals that were approved or authorized to treat coronavirus disease 2019 or COVID-19 in primarily outpatients, not hospitalized patients. So there's 2 systematic reviews and 3 clinical guidelines that provide high quality evidence for the efficacy and safety for ritonavir boosted nirmatrelvir or Paxlovid, molnupiravir, and remdesivir for the treatment of COVID-19. So if we could go to the next slide, please. So this table has been adapted to the table that's on page 221 of the packet. Additional drug information is also in Appendix 1 on page 231 of the packet. So I will just draw your attention to the fact that molnupiravir still has an EUA. It hasn't received the FDA approval yet. Nirmatrelvir, ritonavir boosted nirmatrelvir did get FDA approval for adults last May. The EUA is still in effect, though, for pediatric patients, which went into effect December of 2021. And then remdesivir got the FDA approval back in 2020. So you can see that there's most of these are approved for adults. Remdesivir, this table is slightly different. It recently got the approval in February to use in children from birth. When we first did this review for the February packet, the FDA label was still just for children that were, I think, a month or older. So now it's from birth. And so molnupiravir is the only one that's only approved for adults. And the difference between the three is we have 2 oral agents, and then remdesivir is an IV infusion. The 2 oral regimens are 5-day treatment, where remdesivir is 200 milligrams on the first day, followed by 100 milligrams for 2 days. I'm not going to go into the details of the drugs. I think a lot of us are familiar that have lived through COVID of the different treatment regimens. And so we'll just go through the evidence. So next page. So in 2023, there was a Cochrane review that basically looked at the evidence for the efficacy of remdesivir. Most of the studies that were included looked at hospitalized patients. There was only one randomized controlled trial that was conducted in outpatients who had mild or moderate symptoms that started less than 5 days prior to screening and were at risk for progression to severe disease. So the primary outcome for this randomized control trial was a composite of hospitalizations or death by day 21 compared with placebo. And this randomized control trial did show that remdesivir decreased the risk of hospitalization by 28 compared with placebo. The evidence for mortality was not available because no deaths were reported in either arm of the study, so it was impossible to determine the impact on mortality. Compared with placebo, there were less serious adverse events in the remdesivir arm, which is interesting. You would think it would be the other way around, but there was no difference in adverse events of any grade between arms, but just less serious adverse events in the remdesivir arm. Next slide, please. So there was a 2022 Cochrane review that basically looked at Paxlovid, and this was a much larger trial in outpatients. This was conducted, the studies that contributed to this randomized controlled trial was primarily conducted in unvaccinated outpatients because the vaccine wasn't yet available when they were conducting those studies. And it was in patients that had mild to moderate symptoms that started less than 5 days prior to screening. Again, the primary outcome was composite of hospitalizations or death by day 28 compared to standard of care plus placebo. And they did show that ritonavir boosted nirmatrelvir reduced all-cause mortality at day 28 versus placebo. That was low certainty evidence, and then also reduced admission to the hospital or death within 28 days. Again, that was low certainty evidence. There were more side effects with the ritonavir boosted nirmatrelvir, primarily the metallic taste sensation and diarrhea, compared with the standard of care plus placebo. Next slide, please. So now we'll get into some of the guidance. So in 2023, the National Institute of Health came out with some guidance, and they basically recommend ritonavir boosted nirmatrelvir as first-line treatment for high-risk outpatient adults with mild to moderate symptoms of COVID-19. Second line is in intravenous remdesivir. If the oral Paxlovid is not clinically appropriate, or if there are significant drug interactions with the Paxlovid. And then finally, molnupiravir is alternative therapy if it's not feasible to use the preferred agents or clinically appropriate. So they do recommend, because of the risk to the fetus, the NIH panel recommends against using molnupiravir for pregnant patients unless there's no other options and the therapy is clearly indicated. This recommendation was based on expert opinion, not on any published evidence. Next slide, please. Then the IDSA came out with guidance that was very similar to NIH. They recommend remdesivir if started within 7 days of symptoms rather than no remdesivir. Again, they recommended ritonavir boosted nirmatrelvir if it started within 5 days rather than no treatment at all. And then again, for adults 18 or older, molnupiravir is considered last line if there's no other treatment options. And you can see that all of these were conditional recommendations based on low certainty of evidence. Next slide, please. And then the National Institute of Healthcare and Excellence from the UK. NICE is very similar to NIH and IDSA. They consider Paxlovid or remdesivir as first or second line treatments, respectively, in outpatients with mild to moderate COVID who are at high risk for progression to severe disease. And molnupiravir is considered third line treatment in adults with no other treatment option. Next slide, please. So there is some guidance for antiviral use in special populations. Again, I talked about the drug interactions with Paxlovid. So screening should be done for drug interactions and then a plan implemented to prevent adverse effects if there is a drug interaction. If patients have impaired renal function, if their GFR is between 30 to 60, the dose of Paxlovid should be reduced. It's not recommended if people have severe renal impairment, GFR less than 30 mils per minute. Again, molnupiravir is not authorized for use in pediatrics because it can affect bone or cartilage growth. And it's also not recommended for pregnant individuals due to the risk of fetal harm that was observed in animal models. Next slide, please. So the recommendations are to create a preferred drug list class for the antivirals that are FDA approved to treat COVID-19. So right now, that's basically ritonavir boosted nirmatrelvir and remdesivir. As I mentioned earlier, the pediatric patients aged 12 to 18 can only get the Paxlovid through the FDA EUA. Paxlovid is only FDA approved for adults. Since molnupiravir is only available through the EUA, it will not have PDL status until it is FDA approved. And if it does get FDA approved, we would recommend making it preferred on the PDL with age restrictions, not limiting it to patients that are 18 and over due to the risk of adverse effects. Any questions from the committee about the antivirals? And I don't.
Nice job, Deanna. No public comment. Any questions for Deanna? Again, the recommendations to add the COVID-19 antiviral class PDL and designate the ritonavir boosted nirmatrelvir and remdesivir preferred. And if approved by the FDA, to make molnupiravir preferred on the PDL with age restrictions in patients less than 18 due to the risk of adverse effects. We have a motion to approve those two.
Motion approved.
Thank you, Eddie.
Second.
Thanks, Tim. All those in favor?
Aye.
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 Anybody opposed? Anybody abstain? Fantastic. Thank you. All right, we're going to turn your attention to page 234 if you're following on the packet of materials, and we'll turn it over to Dave Engen.
All right. Thank you, Roger. Yeah, so Today we'll be evaluating the evidence for safety and effectiveness of two drugs, pegcetacoplan and its brand name Syfovre, and avacincaptad pegol, and that's Izervay. Pegcetacoplan was approved by the FDA, and both of them were approved in 2023. They're complement inhibitors, and they're indicated for the treatment of geographic atrophy, secondary to age-related macular degeneration, or AMD. So what is AMD? Let's go to the next slide. AMD, it's a progressive retinal disease. It's the leading cause of irreversible blindness in adults over 50. Patients with AMD have notable deterioration in photoreceptors and retinal pigment epithelial cells. In the early to intermediate stages of AMD, there's significant accumulation of yellowish white protein and lipid deposits, or drusen, that accumulate on the specific areas of the retina. There may or may not be macular pigmentary changes that are evident. Once we get into late AMD, it has two forms. One's geographic atrophy. It's kind of the end stage of dry AMD. And there's also neovascular, also known as wet AMD. The neovascular AMD involves abnormal growth of blood vessels into the RPE and the subretinal space. That's where hemorrhaging and severe retinal damage can happen pretty quickly, like over days. So it's a medical emergency. Geographic atrophy is more of a gradual process, usually over years, and that's evidenced by extensive depigmentation and degeneration of the RPE and the photoreceptor cells. There's also atrophy of the capillary bed and the choroid. There's no cure for AMD, and the overall goal of therapy is to prevent vision loss through slowing down progression, basically, of the disease and preserving visual acuity. Next slide, please. The diagnosis and assessment of AMD progression requires comprehensive imaging of the retina, of course, and then each type of examination kind of gives a unique view to allow differentiation of the clinical findings and characterization of the lesions. They also do assessment of best corrected visual acuity. It's essential to establish a baseline and monitor progression of AMD. So let's look at the drug. So as mentioned, there's two complement-based therapies available for the treatment of GA. Complement, they're proteins that play a role in tissue inflammation. So pegcetacoplan, it targets C3, and avacincaptad, it targets C5. And both of the agents are injected directly into the eye, and each has its own dosing regimen. The pegcetacoplan has a bit wider range of when it may be given, as you'll see there on the chart. But once again, neither drug was apparently designed to stop or actually improve GA. It's just to slow down the progression of disease. So the next slide talks a little bit about the clinical trials that were that took place for each of these agents. So the efficacy and safety of pegcetacoplan and separately the avacincaptad pegol for treating geographic atrophy of AMD. It was evaluated in there are 4 trials, 2 for each drug. They're phase 3, basically all of them, 2 for each agent, as I said. So for pegcetacoplan, the OAKS and DERBY were represented, and the avacincaptad, PEGOL, it was Gather 1 and Gather 2. They're all multi-center, sham-controlled, double-blind trials. You can see there are over 600 patients in the Oaks and Derby, and Gather 1 and 2 had 286 and 448 respectively. Generally, older patients represented, mean age of 78 years, about 60 to 70% female. Gather 1 and 2, actually, they also reported smoking status, which of course, it's an important modifiable risk factor for AMD. And a third to a half, it appears, were active smokers. Patients in both trials were excluded for various reasons, such as GA from other causes, or if they had active choroidal neovascularization or active ocular disease or infection. Gather 1 and Gather 2 also excluded patients with cardiovascular disease. In both trials, the primary outcome was assessed at 12 months. So if you go to the next slide, excuse me. In all studies, the primary outcome focused on GA lesions, either the size or the rate of change at month 12 compared to baseline. And you'll see that for pegcetacoplan, one of the two trials demonstrated statistically significant reduction in GA lesion growth from baseline compared to sham. And the monthly administration appeared to have better results with up to 22% relative reduction in size. The two trials for avacincaptad, the Gathers, reported statistically significant reductions in GA growth rate, 27% and 14% respectively for 1 and 2. The percent reductions are relative though. So in the comments section, I highlighted the absolute differences in actual measurements. And that range was anywhere from 0.2 to looks like about 0.4 square millimeters. And in the Oaks trial, the FDA reviewers actually didn't consider the difference to be clinically significant because it was less than 1/5 the size of a normal blind spot. So it was interesting. If we look at the next page, we'll just briefly go over safety. Here I've highlighted the adverse effects of the pegcetacoplan. Sorry, if you could forward to a couple slides. Yeah, and we'll come back to the other limitations. Yeah, so you'll notice higher rates of neovascular or wet AMD, vitreous detachment, and conjunctival hemorrhage compared to placebo. I have the relative percentages there. So those, of course, are things to monitor and watch for. Go to the next slide, please. Yeah, so for avacincaptad, we also see higher rates of conjunctival hemorrhage and neovascularization, but also increased intraocular pressure, more so than in the sham group. And the relative percentages are there as well. So if we look at some of the trial limitations, if you could go back a couple slides, thank you. So for pegcetacoplan, one of the two trials, as mentioned, met its primary endpoint for significant change in GA growth. Neither the Oaks or the Derby, they reported any statistically significant benefits in functional improvements or quality of life measures. And we're uncertain whether pegcetacoplan therapy increases the risk or hastens conversion to wet AMD. And really the long-term safety and efficacy is unknown. As we saw, about a quarter of the patients actually discontinued treatment by month 24. If we look at the other drugs, so avacincaptad, there were no statistically significant benefits in functional improvements or quality of life measures, so kind of the same issue. The trials were only 1 year, or that's the information that we have. Not really adequate to assess outcomes for a progressive disease like AMD. So long-term safety and efficacy of this agent is unknown. So with that, developed some proposed PA criteria I'd like to go over with you. Excuse me for a second. Sorry about that. So on this first page, it's pretty standard. We actually did, there's one, something I need to edit on there. The initial length of authorization is actually 12 months, so I will get that changed. But let's go through the criteria, and you can ask questions after if you have any questions. So first of all, we ask for a definitive diagnosis, and then we make sure that there's no contraindications. And in number 4, we see if it's a request for continuation. And if it's not, we move in number 5, make sure that's being prescribed by a specialist. Number 6, we get a baseline visual acuity assessment, make sure that that's been performed. And then in number 7, we make sure there's no duplicate therapy, and that if there's duplicate therapy, that it's stopped if it's going to be a switch. So next page, please. Number 9, make sure that therapy isn't started if there's active neovascularization present. And then number 10 is a confirmation of appropriate dosing. So if you just briefly look at the renewal criteria, at least for avacincaptad, there's only one, they're only allowed to have 1 year of therapy, and that's just part of the FDA labeling. So we ask questions to ensure that. And then number 3, just making sure there's no toxicities, harms, or rapid decline in visual acuity. And number 4 requires that a specialist prescriber attest that there's a clinical benefit attributed to therapy. And if there's a benefit, then they're approved to continue another 6 months. And 6 months was chosen because follow-up for patients with AMD, it's suggested to be anywhere from 6 to 24 months, American Academy of Ophthalmology and others. Since these drugs are for patients with late AMD and there's some safety risks with therapy, we thought 6 months was prudent. However, if the committee feels a longer reauthorization period is warranted, then feel free to share your thoughts. But as far as the recommendations on the next page, it's to create a new preferred drug list, PDL class, ophthalmologic complement inhibitors, and designate pegcetacoplan and avacincaptad pegol as non-preferred on the PDL, and to implement prior authorization criteria for complement inhibitors to ensure appropriate and safe use in FDA-approved indications. So with that, happy to address questions, and there may be some public comment after that follows.
We do have one member of the public wanted to provide comment, but first, are there any questions for Dave? Good job, Dave. All right, hearing none. Jamie Tobit, pharmacist with Apellis Pharmaceuticals. Are you able to unmute your line?
I can if you can hear me. Yes.
I can hear you.
Great.
The floor is yours.
Thank you. And thank you, Dr. Hagen, for your great review. I'm Jamie Tobit with Medical Affairs at Apellis, here to discuss, obviously, pegcetacoplan and Syfovre for geographic atrophy, which I abbreviate as GA, secondary to age-related macular degeneration, or AMD. As he stated, it's a GA, it's an advanced form of AMD characterized by progressive and irreversible loss of cells in the retina. Now, wet AMD and GA are not the same. They are distinctly different. However, they can and do occur independently and concurrently in the same patients. Today, I want to speak about seeking clarity about some of the proposed criteria. My first one is around clinical criteria number 9, asking if the patient does have active choroidal neovascularization or wet AMD. If yes, then the request is denied. The criterion does not specify whether or not this applies only to the eye to be treated or to any eye. I would like clarification because about a third of patients with AMD will develop naturally GA and wet AMD, which can be appropriate for treating both if clinician decides. While patients who do have a history of wet AMD in the study eye were excluded from our trials to avoid confounders, patients who had wet AMD in their other eye at enrollment were allowed to be treated. And the patients who developed new onset wet AMD in the trials were able to stay in the study, with 96% of them being treated with the anti-VEGFs and pegcetacoplan. Additionally, the Syfovre label does not limit or restrict use in the wet AMD patients. My second question is about the proposed length of authorization. It states 6 months initially with a lifetime treatment not to exceed, as you mentioned, 12 months. Now, given the chronic nature of GA and the expected impact of pegcetacoplan on lesion growth, 6 months is not enough time for a clinician to objectively measure an effect. Our phase 3 studies, the primary endpoints were taken at months 12 and at 24 at the request of the FDA. And while we agree that an attestation of tolerability at 6 months is reasonable, an efficacy assessment at this time point would provide little valuable information. The Syfovre prescribing information has no maximum treatment time listed. Given pegcetacoplan's increasing effect over time, the recommendation to stop therapy after, as you said, 12 months is not supported by clinical data. We are continuing to assess long-term safety and efficacy of pegcetacoplan in the GALE study, a 3-year open label extension trial that's for patients who completed our clinical trials. This will give up to 5 years of data, and at the when we're all done, and at the 12-month data cut, we showed that monthly and every other month dosing showed increasing effects over time with a 35 and 24% additional slowing of growth compared to sham in year 3. The limitations included is a open label trial with statistical hierarchy and bias. But the adverse events profile of GALE was similar to seen in Oaks and Derby, which were listed in our profile. I see I'm out of time, so I will pause and answer any questions that are available.
Yeah, I'd be happy to address your questions. First one, just want to make sure that you're aware. So number 10, the initial authorization period is actually 12 months. It's not 6 months. So that has already been changed from the draft posting, the original draft. So the one that's up now says 12 months. And so I wanted to point that out. But it is true, the renewal criteria, it is 6 months increments. Now, you had mentioned a 12-month cutoff, but that does not apply to your drug. That applies to avacincaptad. So if you look at the renewal criteria, it says, is this request for avacincaptad PEGL? Yes, go to number 2. No, which would be pegcetacoplan, you would just skip to number 3. So so that wouldn't apply in that case.
Thank you. It wasn't completely clear. I appreciate it. Thank you.
Oh, sure. And the other question you had, so I believe it was number 9. So basically, you were looking for clarification if it said, does the patient have active choroidal neovascularization or wet age-related macular degeneration in the eye being treated? Is that what you're looking for?
Yes, because we allowed patients in our trial if they had the wet AMD in their other eye that was not being treated.
Okay, so I guess I will leave it up to the committee to discuss that. If, you know, a patient did have active choroidal neovascularization, whether you as committee members would want to see your patients being prescribed additional drugs without having that being treated first. So I'll just kind of leave that up for discussion, and hopefully we can come to a consensus.
Questions from the committee or thoughts? All right. Any other questions for Jamie? Great. Thank you for your testimony.
Thank you.
You bet. So the recommendations again in front of the committee, add the ophthalmic complement inhibitor class to the PDL and designate pegcetacoplan and I can't say it, Dave. The other agent non-preferred, and that implement the proposed criteria to limit use to FDA-approved indications. Discussion or move to approve?
I move for approval.
Appreciate it, Doug. Second?
Second.
Appreciate it, Eddie. All those in favor?
Aye.
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 Anyone opposed? Any abstentions? All right, one more topic to get through. So draw your attention to page 258 in the packet. We have the phosphorus binder class update, and we'll turn it back over to Deanna's capable hands.
Oh, well, thank you for that, Roger. Congratulations, Dave. You got the tongue twisters this time, and you did a fabulous job pronouncing those drug names. Well done. So we're going to talk about the phosphate binders. I'll try to get through this as quickly as I can since we're close to time. Next slide, please. So we're going to look at the evidence for safety and efficacy of phosphate binders since the last time the P&T talked about this drug, these drugs. And then there's a new phosphate absorption inhibitor on the market, tenapanor or Xphozah, that we'll be looking at. Thanks, Sarah. This table is, it's on page 261 of the packet in more detail, but this just gives you a high-level overview of the different phosphate binders. So the aluminum binders were available in the 70s, and they're discontinued now because there was a lot of adverse effects from them. So then we progressed to the calcium-based binders. Due to the hypercalcemia, we saw non-calcium-based binders come to market. And then finally, in the last 20 years or so, we've seen the iron-based binders. Next slide, please. So NICE guidance for use of phosphate binders is that calcium acetate should be used in adults with chronic kidney disease that's stage 4 or 5 and hyperphosphatemia. If calcium acetate's not indicated, in other words, if they have hypercalcemia or low serum PTH levels, then sevelamer is the next best candidate. And then finally, if those two agents can't be used, to switch to the iron sulfate products. And then only consider lanthanum if other phosphate binders cannot be used. That's for adults. The guidance for children hasn't changed since 2013. And basically in children, the recommendation is to use calcium-based phosphate binders. Those are the only ones that have been studied in children. Next slide, please. So this new drug, tenapanor, the FDA-approved indication is for add-on therapy in adults with chronic kidney disease that are on dialysis, and it's to reduce serum phosphate in patients who haven't had an adequate response to phosphate binders, or if they can't take the phosphate binder. Typically, phosphate binders are taken 3 times a day with meals. Tenapanor works a little bit differently than the other phosphate binders. It inhibits the exchange of the sodium hydrogen for phosphate in the intestine and colon, so that reduces phosphate transport by blocking the phosphate intestinal absorption. Originally, these tablets were approved in 2019 to manage constipation, predominant irritable bowel syndrome. So there is another brand name product called Isbrella that's on the market as well. The next slide, please. So there were 3 randomized control trials that evaluated the safety and efficacy of tenapanor. They were all a little bit convoluted in their study design. The first one was originally a dose-finding trial, so it started out as a phase 2 and it morphed into a phase 3 trial. The second one was a 4-week trial to look at the reduction in serum phosphate. And then the last one, it was only double-blinded, placebo-controlled for 12 weeks, even though it was conducted over 52 weeks. Most of the assessment was open label. So all 3 of them were looking at the least square mean change in serum phosphate over 4 to 12 weeks. No minimally clinically important difference was identified for that change. But all 3 trials did show a statistical significance in phosphate lowering. Next slide, please. And then the secondary outcome of looking at who achieved a serum phosphate less than 5.5, that was only assessed in the second study, the Amplify study, and they did show a statistical significance in getting people under 5.5. It wasn't reported in the other 2 studies. Next slide, please. So the trial limitations are basically, these trials all looked at phosphate lowering over 12 weeks at the most. So they don't really give us evidence for long-term safety and efficacy of tenapanor. And we don't have comparative evidence between tenapanor and other phosphate binders on relevant outcomes, such as serum phosphate reduction, mortality, bone metabolism, or cardiovascular events. And like I mentioned, that third trial was mostly open label for 40 weeks and only 12 weeks were conducted in a double-blind randomized fashion. Next slide, please. In clinical trials, the most common adverse effect with tenapanor was diarrhea, and it was reported by quite a few patients, 43 to 53% of patients. Severe diarrhea was reported in about 5% of patients. This drug is contraindicated in patients that have known or suspected mechanical GI obstruction. Next slide, please. So our recommendation is to revise the name of the PDL class from phosphate binders to phosphate binders and absorption inhibitors due to the unique mechanism action, maintain tenapanor as non-preferred, and amend the PA criteria to provide coverage for clinically appropriate use of tenapanor as add-on therapy. So let's go to the PA criteria. So the biggest change, this is pretty much the same except for adding questions 4 and 5. So is the request for tenapanor? And if so, is it to use it in addition to other phosphate binder therapy in patients with CKD that haven't responded to phosphate binders or can't take the dose that they're at? Next slide. And then that should be number 6. Sometimes when I paste these on here, the PowerPoint changes the number, so I apologize. But basically, we want to make sure that before they go add tenapanor, that they've either tried one of the preferred binders, which is either calcium acetate or sevelamer carbonate. And then if there's other reasons, if they're wanting to use this for EPSDT language, that's in number 7 there. That's all I have. Are there any questions from the P&T committee? Don't think we have public comment.
Correct. Good job, Deanna. Any questions for Deanna on the presentation? Again, recommendations are in front of you. So revise the name of the class from phosphate binders to phosphate binders and absorption inhibitors. And maintain tinapor as non-preferred and amend the PA criteria to allow coverage for clinically appropriate use as an add-on therapy in hyperphosphatemia, CKD. And then we're going to go look at cost and exec.
Motion to approve.
Thank you, Eddie.
I'll second.
Thank you, Tim. All those in favor?
Aye.
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 Anybody opposed? Any abstentions? Fantastic. A lot of work we've gone through today. We need to go into executive session to look at some confidential pricing. I need to read a blurb with my radio voice. We will have a breakout room so the committee members and staff can attend the breakout session, so keep them information private. No decisions will be made in exec, and we'll return to open session once that concludes. So with that, the P&T committee will now meet in executive session for the purpose of consideration of information or records that are exempt from disclosure by law. Executive sessions held pursuant to ORS 192-602F and ORS 414-356-1 and 2, which allow the committee to meet in executive session to discuss reviewing confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class that's necessary for the committee to make final recommendations or to comply with the requirements of ORS 414-353. Representatives of the news media and designated staff shall be allowed to attend the executive session, and all other members of the audience are not permitted to attend the exec session. Representatives of the news media are specifically directed not to disclose any of the deliberations during the executive session, except to state the general subject of the session as previously announced. No decision may be made in executive session. At the end of the executive session, we will return to open session. And with that, I'm going to pause the recording and we'll go into the breakout room. All right, I've restarted the recording. I'm just doing a head count on my panel here. If the P&T committee members, if you could unmute your lines, we'll take final votes, but it lets me do a head count too to make sure that we still have our quorum. All right, I see 7 heads here. All right, I'm going to take these recommendations one at a time. Actually, I think we could lump them together if nobody's opposed to that. I think they're pretty straightforward. So the recommendations after review of pricing and executive session for the VEGF class update was no PDL changes are being recommended. For the inhalers for asthma, which was part of the consent agenda, we'd reviewed that previously. We just looked at some pricing. The recommendation is to make tiotropium capsules non-preferred. For the drugs for weight loss, and particularly for the GLP-1 receptor agonist scan, the recommendation is to make no PDL changes. For the drugs for bowel prep, the class review, the recommendation is to make Moviprep powder packets, Sutab tablets, and Clenpic solution all non-preferred, and to make all of the other bowel prep agents preferred. And finally, for the phosphorus binder class, the recommendation is to make Sevelamer hydrochloride tablets non-preferred. Any discussion? And if not, we'd entertain a motion to approve those PDL recommendations.
Motion to approve.
Thank you, Bridget. Second?
Second.
Excellent. Thank you, Russ. All in favor of those PDL recommendations?
Aye.
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 Anybody opposed? And anybody abstain? Fantastic. We will take those recommendations forward and present them to the OHA. With that, the next meeting of the P&T committee will be on June 6th. Stay tuned. In about a week from now, we'll be posting draft documents for that meeting. And again, thank you all for this important work and your volunteering for this. And we'll give you back 30 minutes. Thank you all, everybody.
Goodbye.
You.
All right.
Thank you. Bye.
Thank you.
Thank you.